All right, we will get started as I'm a punctual person and it's 9:04. So welcome everybody to 2025 SLP Fellows Day. Glad to have you. We're also recording this, so hopefully in the future we'll be able to put that out and give you guys some extra info. I think people will be trickling in as we go along. But we have an awesome lineup today. Really excited to have some experts in transplant psychiatry and CL psychiatry and ethics. So just to do a quick introduction of our speakers today, and then I can't really do them justice, so we'll have them, explain to you what they do as well. But first up, Dr. Shruti, how do you pronounce her last name? Mutalik. Okay. Shruti Mutalik, who is at Mount Sinai. And she is going to give us an overview of what she is doing, the importance of transplant psychiatry at Mount Sinai. And just, to start off, to say thank you very much to PRMS, who is our sponsor. It's our insurance, malpractice insurance provider. And they are excellent. They insure psychiatrists and specialize in that. And I can speak from firsthand experience that they're very good with outpatient psychiatry insurance. So thanks to them for sponsoring this event today. And without further ado, the order of events will be that we'll have our speakers and then we'll have a bit of a case discussion at the end. So hopefully you guys can stay. And if there's anybody in the hospital here around that that wants to come join, tell them to come at any time and join us. All right, so Dr. Mutalik, thanks.
I'm going to set the timer.
I'm going to reset that for you.
All right. Well, hi, everyone. Good morning. Hopefully you're all caffeinated and excited. Happy Fellows Day. I am Shruti Mutalik. I'm one of the CL and transplant psychiatrists at Icahn School of Medicine at Mount Sinai. First of all, I want to say that, I'm so glad that we have a special day honoring fellows, but honestly, every day is Fellows Day because our fellows, do such an incredible job with clinical work and education all year round. So, definitely wanted to kind of acknowledge that. But fellowship is also a very unique year where you can get immersed completely in one area of psychiatry or CL psychiatry or whatever specialty. And maybe develop sort of a niche interest or a passion for it. And so actually in my fellowship at Memorial Sloan Kettering, I was exposed to transplant psychiatry right here at Cornell. And that sort of started this love affair that's ongoing. So since I am starting off this session, even though my true passion is kind of the psychology of altruism and living donors, as you can imagine, recipients vastly outnumber donors. And so I'm going to give a few framing remarks on transplant psychiatry, the role of a transplant psychiatrist, just sort of like 101. A lot of this, especially for my fellows, will be very they've heard it all before, and then talk about the psychosocial evaluation of living donors and also go into the why. Why would somebody go out of their way to undergo a medically unnecessary procedure for themselves, especially for a stranger? So we'll do a little bit of a, intellectual dive into that. So let's start with, why do you think that transplant psychiatrists or psychiatrists need to do or are called upon to do pre-transplant eval? So this is just starting with the basics.
You want to find the best possible candidate. This is a limited resource.
Okay, so bingo, you've spot on. So you hit the nail on the head, Pedro. So, obviously psychiatrists do all kinds of things. We're experts in behavioral medicine, etc., in psychiatric illnesses. So, and a psychiatric evaluation can yield a lot of wonderful things and, set people up for success. But what's unique to transplant, there is such a thing as pre-surgical clearance for for a lot of surgeries, right? Based on the stress vulnerability model. Like you have some, pre-existing psychosocial vulnerabilities, like maybe limited social support as an example, or psychiatric illness, and the surgery itself is a stress. So there is such a thing as pre-surgical clearance, and pre-transplant evaluations are along those lines. But what's really unique to transplant is, as Pedro rightly pointed out, the resource limitation. We live in a world in which we don't currently 3D print organs or, have a very reliable resource for them. Certainly, we're trying to harvest organs like xenotransplantation, et cetera. But if you look at the UNOS website or the organdonor.gov, it's rife with all these statistics that show you that there are many, many more people who need a transplant than organs that are available. 17 people die each day waiting for an organ transplant. Every 8 minutes, a person is added to the transplant waiting list. And speaking of donors, so a lot of people in theory, there are some statistics that show that about 95% of adults support organ donation, but only not even half of them have actually signed up as organ donors. And there is a conversation to be had about the opt-in versus opt-out system. But of course, that's more sort of cadaveric organ donation, right? That's not living donation. And as far as cadaveric organ donation, very few people die in a way that allows for organ donation. And furthermore, using kidney as an example, if you think about living versus deceased donors, actually living donor kidneys often, last longer, statistically speaking, they last longer. The bridge time for dialysis is less. So, yes, there is a real need, and we do depend on the benevolence of individuals to give their kidneys to people or give their organs to people. So speaking about, again, just a little bit of orientation in terms of my role as a transplant psychiatrist. So in different hospitals that have a transplant institute, you can have somebody specializing in some organs. So at our institute, Dr. Lavochkina does heart and lung. Dr. Yadav and I do liver and kidney. And we work with both recipients and donors. So kidney donors and liver donors, kidney recipients and liver recipients. And, the L of CL, right? We always talk about it, but that is really sort of front and center in the transplant world, because you're not just evaluating the patient. And even within that, you sort of have dual agency, right? You're there for the patient, but you're also a steward of this limited organ. But there's also a tremendous amount of liaison work. So that's actually built into my schedule. Like every week, Monday and Thursday, 4 to 5, liver recipient review committee meeting. Monday morning, liver donor review committee meeting. Wednesday afternoon, kidney donor review committee meeting. So that is really sort of built into my role as a transplant psychiatrist. So again, going to the very basics, I think this is something that that we all know. But what is a transplant, right? So it's basically a process, a surgical procedure in which an organ is transferred either from one area of the body to another. And what would that be called? What if it's like, so if it's within the same person, it's an auto transplant. If it's from one person to another, it's an allo transplant. But also, and I didn't put this on the slide, but when we get our liver transplant consults, they always say OLT eval. Do people know what the O stands for?
Orthotopic.
Orthotopic. And what does that mean? Okay, so orthotopic basically means that the organ is actually placed in the same exact location as the previous organ. So heterotopic would be where it is like attached to, like you don't actually take out the previous organ. So I guess technically kidney would be heterotopic, because with kidneys, you don't do explants unless, the person has renal cell carcinoma or they have polycystic kidneys or something. Basically, the new kidneys are placed in the iliac fossa. So just something to keep in mind. There's orthotopic, there's heterotopic, there's allo transplant, there's xenotransplant. And what's xenotransplant? Yes, exactly. So you've heard of, pig hearts, pig kidneys, etc. What is a VC? Oh, actually, okay. Have people heard of this term VCA, vascularized composite allograft? Okay, yeah. Yeah, so basically, you've heard of face transplant, hand transplants, etc. So essentially, a VCA or vascularized composite allograft is when it's not a solid organ that has a single blood supply, but a functional unit that's often a composite of different kinds of tissues. So a face transplant, etc., for instance, or a hand, it's a functional unit, but different kinds of tissues. And as you can imagine, there's probably a lot of like microvascular surgery, et cetera. It's a complicated surgery. So I guess, fun fact, I mean, these are some milestones, I won't go over all of them, but basically the first kidney transplant, 1954, was between two identical twins. They were the Murray brothers. Why do you think that, like, the first transplant was between two identical twins? Right. So you're looking for obviously blood compatibility, HLA compatibility, and in fact, even now, there are some exceptions in certain immune conditions, but for the most part, people who, identical twins that donate to each other actually don't have to be on immunosuppressants, which is, I think, pretty cool. I'll talk a little bit more about these other milestones in a bit, but face transplant, as I mentioned, actually, I did have the opportunity to see the patient that had the first human tracheal transplant at Sinai. So a question for everyone. If you get a face transplant, will you look like the donor?
No.
Why not? Yes, exactly. Okay, so perfect. So I only asked this question because actually when I was looking up VCAs, this was one of the like Q&A about VCAs. And the answer was that yes, the answer they actually gave was yes and no. So yes, because yes, the freckles, moles, scars will be transferred, but the bone structure is also very different. So you will, still look different from the donor. All right. All right. So one basic thing to keep in mind, yes, and of course, this would lead to interesting issues of informed consent. So, yeah. All right. So speaking about protocols, again, just covering some of the, grounding factors. So social workers in recipient teams as well as living donor teams, they assess all recipients and donors for transplant because you need a psychosocial evaluation and UNOS mandates that. However, psychiatry only gets involved when there are yellow or red flags. So if somebody has a psychiatric history, if they have a substance use history, when it comes to kidney, when there's non-adherence, for instance, or actually any organ. But with liver, of course, all alcohol-associated liver disease cases, we have social work and psychiatry. For donors, we have non-directed donors, liver donors, and swap donors. In our institution, by protocol, are seen by psychiatrists, but everybody else is seen by social work. And then if there's an issue, psychiatry does an evaluation. And we'll get into that in a little bit. So speaking of, segueing into sort of my passion, like I said, for living donors and what I'll be focusing on today, I think that, as psychiatrists, we always talk about diagnosis, right? Like, what's the problem and how can I make it better? And of course, that's part of being a psychiatrist and, extremely important. But I was always drawn to sort of the good in human nature, the transcendent, the noble. And so as soon as I heard that, there are some people that, they go out of their way to donate their organs to strangers, I was drawn to that. So a question for everyone. Aren't all donors altruistic? Like, is it not a tautology to say altruistic donor? No, you're shaking your head, Eddie. Thoughts?
Well, my attending once had a case where two women were in a relationship and they wanted a divorce. And the one was an end-stage renal transplant. So the one who wanted to stay in the relationship actually agreed to donate the kidney. And then the one who wanted a divorce felt indebted. So it was a big psychiatric case because it's like, well, on one end, they both understand the damage here. The other end, there's a very big coercion factor.
Right. So I'm so glad you brought this up. And, I'll be talking about this a little bit in frameworks of altruism and talking about how we do our psychosocial evaluation. So yes, that would be an example of, first of all, coercion, which is actually an absolute contraindication for living donation, but also of kind of what I would call pseudo-altruism. It looks like altruism on the surface, but isn't really that. But the reason I brought this up was, we'll go into the philosophical aspects in a bit, but in the literature, by convention, when you see altruistic donor, it typically means a non-directed donor, like donating to a stranger, even though you could argue that directed donors, like even when you donate to somebody you know, that is an altruistic act. I will skip over the bioethics because we have an expert here. But I will just mention double equipoise, because everybody knows like the foundational principles of bioethics, but double equipoise. So clinical equipoise is what we do every day in and day out, right? Like every intervention, you have to balance the risk to the patient to the benefit to the patient. Double equipoise is more of the dyad, risks to the donor balanced by risks to the recipient. So this is interesting because, there may be some recipients that are extremely high risk, right? Or there may be certain recipients that, for instance, liver transplants are also done for hilar cholangiocarcinoma. So it's kind of like, okay, we're subjecting the donor to this process, and it is for somebody that maybe their prognosis is guarded or limited, etc. So there are ethical issues that can arise with that. And of course, no ethical principle exists in a vacuum. So you're also balancing this with autonomy. Like, what do both of them want, right? All right, so donor swaps. So as you can imagine, if you are a blood and tissue match, you donate directly. But swap donors are when you're not a match. You're not a match to your person, but there's somebody else that you're a match for. And one ethical issue that can come out of this is even if you are a match, you're actually helping more people by going into a swap. So is that a conversation that should be had with people? Maybe Jacob can comment on that. And organ chains, of course, can help a lot of people. Okay, so thought experiment for everyone. Show of hands. Can you imagine donating a kidney to anyone in the world?
Do you mean donating it and it could go to anybody, or like donating it to any specific?
Can you imagine just doing it to like you can get to pick the person? Okay, all right. And can you imagine donating a kidney to a stranger?
Probably not.
Okay, so some of the people who, so I guess if anyone, who sort of raised their hand the first time but didn't raise their hand the second time, like, would you be able to say, like, why not? Or, what changed between the first yes and the...
I would worry about, I want to keep my spare. Maybe in case someone...
Right.
In case like a parent or a sibling or a child needs it.
Right. No, so, and it's not fair to ask a personal question like that without maybe, sharing a little bit of my sentiment on it. And that's kind of exactly where I'm at. I see it as a very wonderful thing. And there's a part of me that wants to believe that at some point in my life, I will do this. But yes, I am also holding on to my spare kidney for my mom.
You also might be scared that it'll go to somebody like a hospital administrator, somebody you don't like.
Yes. Yes, absolutely. Yeah. Yes, no, great point. All right. So now I also want to leave you with some deliverables. So I'm starting with a very simple or relatively straight, nothing is simple, but relatively straightforward case. All right. You have someone who comes in with the chief concern of, I have 2 kidneys, some people have none. All right. So this is a 30-year-old male, wants to donate a kidney to a stranger. He heard this podcast and got inspired. He's very certain, 100% sure. He has some history of what we call pro-social behavior, blood donation on the bone marrow registry. So before I ask you what questions we would ask, just quickly. So what are we trying to do here, right? We're ultimately, as clinicians, trying to sort of optimize his outcome, like ensure an outcome. So we want to identify psychological, psychosocial strengths and vulnerabilities that can be optimized. And of course, identify relative and absolute contraindications and maybe come up with a customized plan to set this person up for success. And what that might look like is, going to see a therapist or going to see a connecting to a psychiatrist or building a better social support plan. What questions can you imagine asking this person? Like, what would you want to know?
What their insurance is.
What else? What else would you want to know clinically?
What do they understand about the recovery?
And I will talk about the insurance bit in a bit. Yeah. And what else? So that's one domain. You want to make sure, you have informed consent, right? Risks of the surgery. And I have a slide about that. But what else would you want to know about why this person wants to do it?
What is their motivation, and is there any like motivations that maybe are coercive?
Yes. So essentially, I think that, it's easiest to sort of see this as what you already do and what's different, right? So you would ask the usual psych eval questions. You would ask about psych history. You would ask about, suicide attempts, psych hospitalizations. Do you see a psychiatrist? Do you see a therapist? What meds are you on? What meds have you been on in the past? What substance do you, like all that stuff, right? Which we do day in and day out. Social, developmental, family history. You would do all that. But what's unique is, asking about motivations, the donation process itself, getting a sense of who this person is this on brand? So I've put here on the slide some ways in which people ask this. You can start with something open-ended, like, tell me how you decided to donate. How did you learn about kidney donation? If it is a directed donation, you do want to explore the relationship with the person, because what if it is an abusive relationship? What if there's a power dynamic there? What's your understanding of the recipient's health condition? And I will say, again, that can become sort of ethically interesting, because what if the person is donating sort of under the assumption that this person developed liver failure because of autoimmune hepatitis, but actually it was alcohol. So then, that brings up some issues. Is anyone pressuring you to donate? And of course, this can be explicit and implicit. Sometimes we might need to read between the lines. Also, I do ask these hypothetical questions, right? What if your future children were to need a kidney? What about that? And you sometimes get interesting answers. For the most, I have had someone say, well, I actually didn't think of that. Oh, maybe let me think about it. Then looking for ambivalence, because lingering ambivalence is actually one of the factors that has been associated in the literature with poor psychosocial outcomes and somatic symptoms as well. So, assessing ambivalence in various ways. On a scale of 0 to 100, how sure are you that you want to donate? Do you know anyone who's donated? What was their experience like? One question I like to ask people is, there are many ways of helping others. Why this one? And you get interesting answers, because, I actually said this to somebody and then, may have added that, for instance, you could, volunteer at a soup kitchen or a shelter. And that person actually responded, well, that seems like a lot of time and a lot of work, giving up my weekends for 5 years to donate, to work at a soup kitchen. I would rather just like give my kidney and get it over with. And somebody else actually, I thought, asked something that really I thought was interesting. He basically said that, yes, I've done all these things like community service, etc. But if you're on the subway and you see someone struggling, right, with something, would you not help them because you've already done so much? So I thought that was interesting. I mean, his point was that you help the person in front of you. You don't, even if you've done a ton of other things, right? So you try to get a sense of like what role faith plays, values to live by. In terms of psychometrics, there's actually the living donor assessment tool, which has good internal consistency, reliability that actually encompasses a lot of these questions. Of course, want to know about fears of the donation process. Risk. So again, just quickly. So this is interesting, and it's interesting how you would frame this, but basically the risk of death with a kidney donation is 0.03%, with a liver donation, 0.4%. It's a major surgery, so there's the risk of general anesthesia, pain, infection, bleeding. It's the kidney surgery is done laparoscopically. In our center, the liver is not actually done laparoscopically, but in some centers it is. And, of course, sometimes if the anatomy is complicated, et cetera, it can get converted into an open surgery. In terms of, for the most part, people are actually back on their feet quite quickly, in 2 days or so. Of course, there can be, discomfort, etc. But long-term risk. So this is actually very interesting, because what I'll say is that hypertension, the relative risk increases 3.64-fold compared to people who have not donated. And the estimated risk of end-stage renal disease is actually twice. However, I've spoken to a nephrologist about it, and they brought up a very interesting point that the absolute numbers are very low, even though the relative numbers are high. And there is a further question, which I think even comes into play with psychosocial risk, which is what is attributable risk? Like, would this person anyway have developed hypertension? Yes, we do know that kidneys regulate blood pressure, and, clamping the renal artery increases blood pressure. But how do we know that this caused that? We don't really know for sure. And then there's also gestational hypertension and preeclampsia. The risk is actually 2.5-fold, 2.5 times. And so, there is this interesting question of like, we do sometimes suggest to people, especially if they can wait, like in a non-directed donation, birthing people who can get pregnant, that you might want to sort of, have kids and then do this. So that's an interesting point. What would you think? I mean, I guess this is large enough. I was going to say, maybe, what do people think are the contraindications to donation? Like, when would you say no?
Of course. Yeah.
So yes, coercion is an absolute contraindication. Psychiatrically,
But there's concern for like them wanting to self-harm or possibility of like harm.
yeah. So that's excellent. So again, if somebody's suicidal, if somebody's psychotic, and I'll say a little bit about the nuances of it, but generally, even though there is center-wide variation, in general, we say if somebody is, suicidal, if somebody is psychotic, if they have factitious disorder, there's severe ambivalence, there's concern about an active substance use disorder. And again, in terms of center variance, there was a survey which actually looked at about 195 transplant centers from October 2021 to April 2022. And they actually found that active suicidality, self-harm, psychosis in over 90% of the programs were absolute contraindications. And active depressive disorder in about 50%, anxiety disorder about 27%. And then there was a lot of variation with substance use. I mean, in a lot of centers, it was accepted unless there was a disorder. In our center, actually, you have to have a negative U-tox, even if it is recreational cannabis not meeting the threshold for a disorder. All right, so what are the clinical dilemmas that can come up, right? So there are so many different domains. One is, of course, along the lines of informed consent, like if somebody has an intellectual disability, or there was a case that Anna Dickerman actually published in the JACLP about somebody with dissociative identity disorder, and the question was, do we need consensus between the alters, etc.? That's a great question. Yeah. And then the other thing would be, how much does the donor need to know about illness etiology? I will say clinically, probably one of the biggest things I struggle with is psychiatric history and substance use history. How much, or more so psychiatric history, when do you mandate therapy? Sometimes there's a whole spectrum of stability, right? There are marginally acceptable donors, and there are people who are excellent candidates, even psychosocially. And where do you hold the line? Like if somebody, for instance, was very depressed 6 years ago, but then since then, they've not been in therapy, and maybe they had passive suicidal ideation at the time. They've not been in therapy, they've not been in care, they're doing very well, and they want to donate. Should we say, oh yeah, but you have this vulnerability, maybe you should be engaged in care before you donate? So, I think there are questions like that. And how much time do we have now? Oh, 5. Ooh. Okay, all right. Well, okay, I'll try to go a little fast, but actually there's a lot. But maybe skimming over this a little bit, sometimes you don't know what you don't know. I definitely had, someone who actually didn't reveal that the recipient had sexually assaulted them for several years. And they didn't say that, but then they revealed that later. So these are just some cases. All right. So I wanted to do a little bit of, I'll try to do it fast, but the motivations, right? Why? So altruism is generally required as conceptualizes other-oriented behavior, like doing things that may be at some cost to you, but welfare of other people. Also in moral philosophy, altruism is sort of this idea that you have a moral imperative, or the value of an action is measured by how much it benefits other people. So I wanted to mention this quote, this book, Strangers Drowning, about altruism, in which Larissa Farquhar, who is a journalist, she basically said that cold-blooded benevolence makes us as uncomfortable as cold-blooded malevolence, which I think is interesting because a lot of people, when you talk to them, they will say that, yeah, these donors, there's something a little, askew in their minds, which is interesting. Speaking of Freud and the psychodynamic perspective, so I guess the way I would break down this slide is that there's healthy altruism broadly, and there's pathological altruism. Healthy altruism is, in the world, everybody has sort of a distribution of traits, right? So generative altruism is when you do good out of the goodness of your heart. And some people just have more pro-social tendencies than others. But then there's pathological altruism, which can be conflicted altruism. Part of me wants to do it, part of me doesn't want to do it. Pseudo-altruism, like the case where masochism is sort of masquerading maybe as, or an example of pseudo-altruism would be, I'm suicidal and I want to leave a piece of myself behind. That it looks like altruism, but really isn't. Psychotic altruism would be, is it part of a delusional system, command auditory hallucinations telling you to sort of donate a kidney? And proto-altruism is considered altruism that's, to like your child or somebody that you have really something in common with. Neurobiological perspective. So this is actually very interesting, and maybe people should, look this up. I would encourage you to. Abigail Marsh is this researcher who basically compared fMRI studies of, basically it was healthy controls, extraordinary altruists who were living donors, and people who were psychopaths. And she showed all of them pictures of people with fearful expressions. And what she found was that the people who were psychopaths, their right amygdala volume was lower, and they had reduced responsivity in the amygdala, or reduced sensitivity to fearful facial expressions. And the altruists, actually, the donors, had the opposite. So I don't know if people have heard of the selfish gene by Richard Dawkins. So the idea from an evolutionary perspective is that a lot of behaviors that look very large-hearted and generous are selfish at the level of the genes because they are increasing the probability of the person or whoever they are helping reaching reproductive age and then passing on those genes to the next generation. So I guess to break it down very simply, for instance, parents, you can say, make a lot of sacrifices often for their kids, but they do have 50% of their kids' genes. So that's like one example. But for instance, in bees, right, in the animal kingdom or insect world, there are some drone bees, male drone bees, that actually sort of die for the hive, but they have the same or very similar, some proportion of genetic composition as the queen bee, who actually propagates the genes for that behavior. So just something to keep in mind. And I don't know if people, just a few more minutes. Yeah, I'll wrap up. Game theory. Have people heard of prisoner's dilemma? Does anyone want to explain what it is? Oh. 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 So that's one kind of prisoner. So, so there's another idea that basically, I think that this actually explains a lot of social cooperation. The idea is that, you have two prisoners, and basically if both of them sort of, take the blame or don't, blame the other person, then they'll get the best outcome for both of them. But if you only think about yourself, then the best outcome for you would be to rat on the other prisoner, right? But then if both of them think the same way, both of them will rat, and then they will get a bad outcome. So I don't know if this is making sense, but the idea is that cooperation happens because, everybody thinks the same way, and then it backfires. And so maybe, helping each other out actually gives a better outcome for everyone. And this is Peter, I'm sure Jacob will comment on him, but he talks about effective altruism. Like, okay, let's be strategic about altruism. Let's just not sort of, have these diffuse ideas of altruism. Let's be strategic. There are some charities that can actually help, some organizations whose money goes further, etc. And Paul Bloom is actually a psychologist at Yale who sort of talks about, speaking of effective altruism, that, empathy he describes is a spotlight. Like it's not, so again, this is another case to be sort of strategic about altruism if you really want to sort of make a difference in a utilitarian standpoint, right? Like to help maximize the welfare of as many people as possible. Because with empathy, the way he describes it is that you sort of hone in on something which is something to do with you psychologically. Like if somebody tells a very sort of heartbreaking story and you're on the jury, you might your heart might go out to that person because you're feeling empathic, but somebody else who couldn't present themselves in that way may actually have been innocent. So that's just an example. Yeah, maybe like one of our concluding slides could be, people know who this is. I guess this is one of the most, but do you know the reference? Like, why am I bringing this person up with respect to altruism?
Who is this person? I'm sorry.
Oh, you really don't know? Okay, so does somebody want to tell him? That's her, yeah. Okay, so basically, Taylor Swift has written this song in which she actually says, I was, pretty impressed by this lyric that, my covert narcissism disguised as altruism in her song Anti-Hero. She says, my covert narcissism disguised as altruism like some kind of congressman. So it's interesting because I wanted to look up, is there a link between narcissism and altruism? And basically, there was a study of 286 volunteers looking at the dark triad. Do people know the dark triad? So it's psychopathy, Machiavellianism, and altruism. And they actually found that Machiavellianism is inversely correlated with altruism, which makes sense. Like if you're deceitful, manipulative, maybe you're more into yourself than other people. But altruism, while controlling for everything else, was actually associated with, narcissism was associated with altruism. So just something to keep in mind. There are many frameworks. I'm going to skim over this. Renewal, this is probably the vast majority of non-directed donors that we see. It's an organization founded in 2006, and they give a lot of support to donors, lost wages, childcare, over and above what NALDAC does. NALDAC is basically the National Living Donor Assistance Center, which gives all donors that are legal residents travel expenses, lost wages, transportation, lodging, etc. And I guess, I can, like Jacob, I think that I, can never completely resist being a little bit provocative. So I guess what I'll end on is, I think with ICE and the new administration, there's a lot up in the air about undocumented immigrants, right? And it's interesting because it remains to be seen what will happen, but we have actually worked with undocumented donors a fair amount before. And what I used to always say in my talk before this is that undocumented immigrants are not a monolith. Some of them have great access to care, some of them have social support networks, and some of them do not. And if you think about it ethically, right, a lot of undocumented donors might be coming forward to donate to people that are also undocumented, right? So in a way, it's all connected. So if you're refusing somebody on the basis of them being undocumented, you're actually, doing something that would really hurt their life and their physical and mental health, etc. So just something to keep in mind. And I was going to say that actually, we don't know the statistics on living donors, but with deceased donors, actually, about 3% of deceased donors are undocumented. And I saw that there are some studies showing that up to 70% of undocumented immigrants, when they fill out their license, when they get licenses, etc., they actually do click on, wanting to be a donor. So yeah, and I think I've vastly exceeded my time, but I'll just say that, generally people do well, except for some risk factors like recipient graft failure. There are some large studies like the ReLive and there's a study with liver, etc. Maybe if we have time, I'll get to this in the end. But essentially, my conclusions are there are certain extraordinary altruists in the world. But of course, our role as psychiatrists is to identify, support healthy altruism, but also sort of weed out pathological altruism, identify yellow flags, red flags, set up the person for a good outcome, but sometimes it can be complicated to know, what is a good outcome? Good outcome for whom? If the person keeps saying that, no, I really, really want to do this, there can be this dynamic of the person is begging you to clear them, but you have some concerns, and how do you sort of balance autonomy and, non-maleficence there and beneficence? And remember, a good action can be psychologically complicated too. I guess what comes to mind about that is I was listening to a podcast in which a psychiatrist said that she had donated a kidney, and when they were asking her about that, she said that I was always the kind of person who had this anxiety about fixing things. Like if somebody was lying on the road, I just felt really anxious until I kind of helped them. So yeah, there's that biopsychosocial formulation, right, which makes certain people act in certain ways. So yeah, protect, but don't over-pathologize. All right, and a lot of acknowledgements. I think a lot of people here. Thank you so much. Right. Well, hopefully it didn't exceed too much.
Thank you so much. That was an awesome talk, and also reminded me how far out I am from CL Fellowship, and I don't remember a lot of that stuff. So good reminder. And so I also just want to introduce my brain is on now. I've had enough caffeine. So I just wanted to make sure that I introduce Dr. Jacob Appel as well, because you guys are going to chat a little bit about the ethics of what Dr. Metallic has just talked about. And he is a superstar in many, many different ways, which he doesn't like hearing. But he's a bioethicist, a JD and MD, a CL psychiatrist, an author, a playwright, and lots of other things. So we're really lucky to have him today here. And I will leave it to you guys to have a little chat about the ethics of transplant. And don't mind me while I'm switching out the slides and doing all that. So.
Sure. So I will take over for about 5 minutes. I do appreciate the introduction to my other studying of the rabbi. Now I'm recorded for posterity. I always love coming out and point out that money, by the way. It's like discovering the wealth.
I don't know if that's on.
It's also sort of like coming from a medical school that values artificial intelligence, being in some that you value real intelligence. It's really exciting. But anyway, so back to the ethics at hand. So I think the big thing I want to emphasize is that many of the rules relating to transplant ethics are differences of degree, not of kind. So most of the rules we talk about in ethics, there's some bright line rules. Don't sleep with your patients. Don't poison them in their sleep, etc., etc. Oh, probably not. Or my brain is off, one or the other. How do I turn this on? See? That help? Yes. That is why I am not a transplant psychiatrist anymore. I am an ethicist. So that being said, some of the issues that came up very briefly, somebody mentioned the concept of the best possible candidate for the organ. That itself is a very problematic concept because what defines best interest? Some of you may know, even if the goal is to steward the organ best, that is problematic, but it's also important to remember that was not always the case. So I imagine most of you are familiar with the God Committee in Seattle, where in 1962 at Swedish Hospital, they allocated life-saving dialysis based not on one's likelihood to survive, but on one's social merit. And you actually applied like you might apply for college. We have taken that in some ways to the extreme. So, for example, there was a case in Oregon a few years ago where somebody on death row was found by the courts to be eligible to receive an organ because that would actually steward the organ better than other candidates because the average life expectancy on death row in Oregon is about 13 years, longer than the kidney would be. But it also raises complex questions. For example, you see a patient who has had a Tylenol overdose and is not awake yet and can't tell you whether they want to live or not. Are they an appropriate candidate for stewarding an organ or not? Obviously, if we did not have a scarcity, none of these would be issues. But the big issue that Dr. Metallic brought up, I think that is sort of the core of her discussion, is how much risk we tolerate people accepting. And some of you may, one of my rare film appearances, I appeared in a movie called Confessions of a Good Samaritan. This is not like a blockbuster Hollywood movie. It's an obscure documentary in which the filmmaker Penny Lane went to NYU and donated one of her kidneys to a stranger. And she actually filmed it. I'm impressed they let her do this. The question that she posed when I actually talked to her about this is, why are you evaluating people who are thinking about giving organs to strangers and not the people who aren't giving organs to strangers? If you saw a child drowning in a pond and you had a 0.4% chance or a 0. Whatever it is for kidneys chance of dying, saving them, I think all of us would agree you have an ethical, if not a legal obligation to save the child. So why, if someone needs a kidney and they're in the hospital across town, does the same obligation not exist? And beyond that, there are certain risks we simply won't take. We don't allow you to donate your cornea to a stranger. We don't allow, or even a friend if they can't see. We don't allow you to donate your hand, or presumably your face. There is a protocol for mine is in low demand anyway, but that's a different story. There actually is a protocol which has never been used for living donor heart transplant. And in theory, if you had some kind of other terminal illness that would lead to your demise and you wanted to switch to a BIVAD and give your heart to someone else and possibly expire, somebody designed a protocol for that. We do not let people do living donor heart transplants, even though many people would say, I'd be glad to sacrifice my own life to save my child. In other contexts, we find that perfectly acceptable. In fact, many of the risks we take, and I will add, by the way, they appear very different if you frame them not as 0.4%, but as 1 in 200. We would not take in most social situations, but we would take to save a loved one, independent of any other factors. The second issue she brought up, and some of you have talked about, is the concept of coercion. But what exactly do we mean by coercion? Coercion is really a matter of degree, not of kind. All of our social relationships involve some level of power dynamic and some level of coercion. She also touched on the issue of prioritization in terms of who takes priority for living donor organs. And we only got a bit of discussion about renewal, but I do want to emphasize, so Renewal is an organization, for those who are unfamiliar with it, who recruits members of the Jewish community, which, for full disclosure, I belong to, so I can make a little bit disparaging comments about my people. But the we're on Zoom, so I'll be in good behavior. But the organization recruits from the Jewish community and earmarks its kidneys toward other members of the Jewish community. So on the one hand, one might say that's helpful because a rising tide raises all boats. We then increase the pool, for example, of available kidneys, so other people who couldn't otherwise get kidneys are then eligible. On the other hand, if the perception comes around that the Great Mount Sinai Hospital gives kidneys to Jews preferentially, that may make people from other communities not donate their kidneys. And I will add, people have tried to set up similar systems in other communities, particularly among African-American churches in New York City, and it has failed, possibly because of lack of trust in the system or a lack of belief that the organs will actually be allocated in the way they're promised to be allocated. I do want to raise one more question for us to think about. So we talked a little bit about, hinted about equity, and I'll talk a little bit more about equity as we go on through this discussion. But I want to suggest to you at baseline, the illusion the system is equitable is a false one. Many of the criteria that Shruti mentioned that may seem neutral are not. So for example, we say you need to have social support. Social support is not a neutral characteristic. If you are Jeff Bezos or Bill Gates, you can buy social support. You can hire someone to do it. Why does Medicaid pay for you to have a home health aide if you can't walk or need help with your ADLs, but it does not hire someone to perform social support if you need to have a transplant? Food for thought. We have a system that allows you, and we've learned that different transplant centers have different criteria for getting an organ, both psychosocially and medically. People will go from center to center. If you are well off, you can get yourself listed in multiple places, travel from multiple places, rent a motel room, buy a mansion. If you're not, you can't do that. So any discussion of allocation of organs has to occur under the baseline understanding that it is not equitable to begin with. And that was about 5 minutes, so I will stop there and turn it over to our next speaker for now.
Yeah, great. Who's Dr. Joshi? Okay, great. Well, my pleasure to introduce someone that I've just had the pleasure of meeting, Dr. Nishi Joshi, who is at Northwell Health and an expert in heart and lung transplant, as well as developing training programs in the CL world. So she's going to be sharing with us her take on the psychosocial care in heart and lung transplantation. And I'll give you your little there. Cool.
Thank you. So good morning. I'm from Northwell. If you guys have any questions, my fellows are sitting in the last row. Thank you guys. So we actually, I actually do see all of the liver, kidney, heart, and lung patients. It's quite comprehensive to cover lung and heart, in addition to speaking about kind of the program development. So I can definitely step aside later on and talk a little bit about the program development aspect, because I know we are short on time. So no financial disclosures, kind of the objectives. I think Shruti kind of covered this pretty well. The reason why I'm going to go through this again is I think it ties into the building or the framework for what's needed for a transplant psychiatry kind of service. So when I started as a fellow, I was a fellow at North Shore LIJ. We didn't have a Northwell Transplant Institute, so this was quite new. And it took a lot of kind of effort for us to actually develop the transplant psychiatry service line. And a lot of it came down to kind of speaking to the key stakeholders and trying to make them understand what is a transplant psychiatrist. So I remember when I went to my current, one of my bosses, who's a surgeon, I explained to him, we need a transplant psychiatrist. He's like, that's a thing? I was like, yeah, we get training in consult liaison psychiatry. He said, that's a thing? So, they don't know what they don't know. So what is transplant psychiatry? And I know Shruti kind of covered this. So, obviously, I think we're all aware that these are the assessments for pre-transplant evaluation. We want to address any potential barriers, any psychiatric concerns that we can amend so they can become kind of viable candidates from the psychosocial standpoint. It's to address these needs and optimize these patients for transplantation, but it's a little different from the traditional role of a consultation liaison psychiatrist in that the patients have to be aware that we still are kind of representing the transplant team as well. So nothing that they share is going to be in complete confidence, right? We're working with both kind of the transplant team as well as the patients. And we are going to continue being an advocate for these patients, but we can't, withhold information, which I know can be a little challenging to build rapport, especially in our liver transplant patients. And I know Dr. Shenoy is probably going to get to that. So you really want to assess coping skills, baseline assessment of cognitive function to monitor for postoperative change. Very, very important. I know it's very challenging in our abdominal transplant patients, but we've noticed this in our heart and lung patients. Baseline cognitive function kind of is predictive of how they're going to do postoperatively. If they have any pre-transplant cognitive deficits, they actually end up having, statistically speaking, longer hospitalization stays due to delirium. And as you know, delirium, it is related to mortality risk, and it will cost the hospital money. At the end, money talks. So anything that kind of is going to cause prolonged hospitalizations, poor outcomes, we want to address prior to, right? And then we want to gauge presence of social support. So it's very important that these patients are well kind of supported, and you'll see why that's essential in our cardiothoracic patients. This was kind of the same thing, just the framework in terms of what is our role. So I think everyone is aware about the pre-transplant evaluation, the psychosocial evaluation to deem if this patient is an appropriate candidate, but the role doesn't end there. And that's kind of where, when we were kind of talking about the role of transplant psychiatry and why it's a necessity for our institute, my role doesn't end there. I follow their journey through the perioperative, postoperative period. And we kind of follow them even outpatient and see their journey. And it's very important. We've gotten great feedback from these patients. They go through a significant amount of psychological distress in the preoperative period. And even postoperative, when things are supposed to be quote unquote great, they actually do worse, after they get discharged. And I'll explain a little bit why. So these are other tools that, psychometric tools. I was told to talk about general transplant psychiatry, so I apologize. It's not as interesting as Shruti's talk, but there's PACT, the TERS. This is not comprehensive by any means. I'm going to go. We don't use any of these tools, obviously. We use the SciPath. So my fellows are probably like cringing in the back because I think they've memorized this by now. But we use the Stanford Integrated Psychosocial Assessment Tool. And, when we're talking about transplant psychiatry evaluations, this is the one thing that kind of will kind of give you a good idea of what it is. Essentially, we're doing a capacity evaluation, right? Is the patient understanding kind of their own illness? Are they able to relay and understand kind of and teach back the treatment team's recommendations? And at least for our cardiac patients, I find this, it's so convoluted because we have a team talking about advanced therapies in terms of Impellas and LVADs and IABPs. Like there's so much going on. They get a little flustered and overwhelmed. And so part of our role is to kind of really gauge their understanding and kind of work with them. Social support, I think we've already touched on. Risk of psychopathology. So these are things that I think they're kind of like from our end, actionable items. Is there something that we can address or treat preoperatively that's going to help them postoperatively? So this is just a risk stratification tool. So I'll tell you that, specificity and sensitivity was, I know it did well and good in terms of inter-rater reliability, but it's not, a person is not a PsyPath score, which is important because I know at my institution, the surgeons have even memorized this. They have an idea of where they fall and in terms of their risk. It's just a risk stratification tool in terms of how well they'll do. Now, what is well? Is it compliance with medications? Is it abstinence from substances, which I know I'm going to defer to Dr. Shenoy because he's going to have alcohol as a topic. So what can we do to, help them have proper outcomes? And is there anything that we can do in terms of actionable items? So psychological timeline of organ transplantation, this is not kind of limited to our heart, lung patients. This is actually all of our solid organs. So in the pre-transplant period, there's a decline in function. There's fears of outcomes of end-stage disease while they're awaiting an organ. They have significant demoralization over loss of autonomy. We have patients who have been, working all their lives. I've heard this story, like, I'm a breadwinner. I don't understand why I'm in the hospital for 3, 4, 5 months awaiting a transplantation. Peri-transplant, this is right immediately post-transplant. You might have heard of, quote unquote, the honeymoon period where, everything is looking up. They have a new organ. They feel their life is great. They're hopeful, but they still have this subsequent anxiety. What my lung transplant patients always tell me is they're waiting for the other shoe to fall or drop. Postoperative cognitive changes and discomfort. So this is huge in terms of why we need to really screen them. As part of the PsyPath, we sometimes administer MOCA as well. I don't want to go into that because I know we don't have much time, but you'll see why. I'll talk a little bit about the cognitive kind of decline that we see when we induce these patients on our CNIs and all of this other stuff that happens post-operatively. And then post-transplant, early stages, there's always this fear of or risk of acute graft rejection with recent hospitalizations. They need rehabilitation. As patients tell me, I feel like I'm learning how to walk again. And they expected kind of, I'm going to get a transplant, I'm going to do well. I don't understand why this is taking so long. I want to get back to my life. It's not the same life. It's a new restrictive normal. So we actually, when we're going through the consent process and talking to them, I speak to them about this. Whether they kind of retain it postoperatively, it's debatable, but we always mention, it's going to be a new normal. You're going to have weekly follow-ups. You're going to be on a laundry list of medications. And then there's significant caregiver burnout in terms of the post-operative period in the chronic setting. As the caregivers start, getting a little overwhelmed with taking these patients back and forth to appointments, reason why we always rely on our social support. This is one study. I mean, I thought it did an excellent job kind of showing how all the organs fare in terms of survivability. If you can see, at least from the heart-lung standpoint, there's a significant drop in the survival rate at the 10-year mark, especially for lung. Lung is the last line. And you can see that, compared to the other organs, our kidneys, livers do a lot better. Obviously, live donations tend to fare better. But lung has the worst prognosis. I think on average, it's like 9.5 years or so that they have, there's great outcomes if they don't go into any form of rejection prior to, but they don't do well. And when we are consenting our lung transplant patients, actually, they do tell them this and they do show them this. So I think my lung transplant patients have the best education and kind of have an idea of what is going on. The wait time, too, which is not displayed on here, is actually significantly longer for our cardiothoracic patients, especially our lung patients. So speaking a little bit about heart transplant, the first one, I think Shruti mentioned this, in 1967 was our first human heart transplant. It wasn't successful. The patient died within 18 days because immunosuppression was, we weren't using it till the 1980s. So patient died of pneumonia, but that was first done by Dr. Barnard. What is like kind of the indication for heart transplants? We call them advanced heart failure patients, which basically means their treatment is refractory to any medicinal and or device, any therapy that they're providing. So if they're on inotropic support, they're kind of maxing out on their inotropic support to a point where now we need to go to the next stage. That's ACC or AHA heart failure stage D or NYHA class 3 to 4. And as you can see, it's significantly, there's significant debility and sarcopenia in these patients. And a lot of times we will see that kind of manifest as major depressive disorder or similar symptoms that kind of like overlap between how severe their heart failure stage is and where they are. So when we do launch, and I'm sure if you know this, I apologize. I know it's going to get redundant, but we do launch our advanced therapy evaluations along with the LVAD is offered. LVAD has been pretty life-saving, and with regard to heart transplant kind of outcomes, we've had a significant increase in terms of survivability and successful outcomes since the advent of the HeartMate 3. The LVAD device. So when we are consenting these patients, we oftentimes speak about this as well. Now, from the psychological standpoint, why is this important in terms of the LVAD? This is an external battery with drive lines going in and out. They are no longer allowed to submerge themselves in water. They have to avoid any contact sports, and it's a pretty restrictive lifestyle. And so a lot of patients will say, I would rather die than be hooked up to this if I'm not a candidate for a transplant. This can be a bridge to transplant. It could be bridge to recovery, or it could be destination therapy if they are not appropriate candidates. And believe it or not, more often than not, the transplant teams determine if they're not a great candidate for transplant if there's acute psychosocial barriers that cannot be addressed. So we've, in my institution, I know if they're actively smoking, within the last 6 months, they automatically kind of say, we'll defer until the patient has demonstrated kind of, the ability to stay away from smoking. Whether the 6 months is actually a rule, I mean, if it's efficacious or not, I think that's debatable. But these, the LVAD patients actually face the same psychological distress that our heart transplant patients face. Lung transplant referrals, same thing, chronic end-stage lung disease. But unlike our heart transplant patients, there is no LVAD option. These patients end up on VV ECMO. I think you guys have probably seen the ICU setting. Unfortunately, have lots of dyspnea and then comorbid anxiety. It manifests as anxiety. But the listing criteria is also a little different. It might seem like the lung transplant teams are a little bit more lenient, but actually, they have to be at high risk of death within 2 years, and they have to basically be able to survive 90 days after a transplant, which is an odd criteria, but it's kind of part of it. And then the progressive disease is still there, just like our heart transplant, where they're using maximal therapy, and there's they're still maxed out on their oxygen and can't do any better. Obstructive lung disease, pulmonary vascular disease. This is where heart and lung kind of meet up. We do a lot of double organ transplants for these patients. CF patients, I think everyone is aware of, and then restrictive lung disease. Okay, so this is interesting because I think Dr. Matalik mentioned psychotic disorders. So it is true, if they're acutely psychotic, actively psychotic, it is a contraindication, but it's not an absolute contraindication if they have a history of it. So I've had patients that have had schizoaffective disorder that are very well connected to psychiatric services, are compliant, are managed really well, and end up doing better than actually most of my other patients. Adherence rates to these medications is equivalent to the general population if they have access to care. That the non-compliance that we see oftentimes, at least in these studies and in the cases that we see, are access. It's an accessibility issue. It's a public health concern more than the patient overtly, being non-compliant. They're not receiving the appropriate care, so they're going to have more episodes of psychosis. Personality disorders, I'd be interested to see how each institution does it. Obviously, it's not a contraindication at ours either. I don't even think it's a relative contraindication at our institution, but we've been running into a lot of challenges with one particular kind of like the cluster B personality disorders recently, especially in my LVAD population. But the reason why that is because borderline personality may need, they need active enrollment in therapy, which we can't provide, obviously, DBT at bedside at my institution. And they have severity of this mood stability. They're constantly negotiating their care. And so there were studies that showed that they actually have the worst kind of like outcomes and prognosis wise, like borderline personality disorder, just patients with borderline personality disorders do the worst. But it's, once again, not an absolute contraindication. Any personality traits that impede cooperation, obviously, with providers are going to lead to poor outcomes. So numerous hypotheses have been proposed for this bidirectional nature of like depression and heart failure. Obviously, we already know the neuroendocrine one, the HPA axis. We have platelet dysregulation, inflammation. These patients tend to kind of engage in risky behaviors. What we see, at least in our heart failure patients, is especially if they have reduced ejection fraction, heart failure, low cardiac output, they have this, they appear emaciated, like almost cachectic, very low mood, the sarcopenia that I alluded to, with significant anhedonia. And so if you're that debilitated, you're not going to be doing anything in terms of to kind of better your life. And so we see that a lot at our kind of institution. This air hunger and COPD patients, this is kind of challenging to kind of treat in terms of the ICU setting, because a lot of the ICU physicians, it might be a matter of changing vent settings, but I don't think they're going to accept the psychiatrist telling them to change the vent. The other thing that I've also had a conversation about is, if it's true dyspnea, opioids are actually indicated. So not high dose opioids. I'm talking about, obviously they have to monitor they're not causing respiratory depression. And I don't think many providers are very comfortable with that either. At least that's what I've faced, unless they're using like fentanyl and stuff in the ICU setting. So heightened stress response leading to incidents of PTSD. We see this in cardiothoracic, actually all of our solid organ transplant patients, but this is specific to PTSD. One thing to kind of keep in mind is if they have pre-existing kind of AICD placement and they've gone through like shocks in the past, those patients have like a 40% incidence also of PTSD, so to screen them. So the two studies, these are not comprehensive by any means, but this I thought it was important because, you might have seen bronchiolitis obliterans. So it comes from this study where, 155 patients were basically followed for, I think like 15 years or so. And the mortality and morbidity risk, they actually developed bronchiolitis obliterans, especially if they had depression like 12 months after, or major depressive disorder, 12 months after their lung transplant. And then this study kind of highlights that honeymoon period where in the acute post-transplant period, quality of life is great. And so you don't see many acute depressive symptoms, but 3 years out, there's a, reoccurrence of it. All right, so this is not comprehensive either, but Shruti told me I had to put something with pharmacology. The only thing that I would take away from this is obviously our CNIs and corticosteroids. I think we're probably all aware corticosteroids, not only do they have, they impact our glycemic index, doses 40 milligrams and higher are oftentimes associated with manic symptoms, right? And we have severe, significant affective dysregulation. I have patients on low dose chronic corticosteroids manifesting as like depressive symptoms as well. The renal function also matters. We've had elderly patients that tend to do worse on corticosteroids, and ones with pre-existing cognitive kind of dysfunction also tend to do, I think, a little worse in the post-operative period. So something to kind of always counsel and coach patients about prior to. I usually include this in like when we're talking about what to expect worst case scenarios. 3A4 inhibition, we talk about this, you want to avoid agents that have strong 3A4 inhibition, fluvoxamine, which we don't really use as much for us, but, fluoxetine, sometimes I know it has 2D6 as well, but as long as it's monitored and managed, I think it's doable. You can continue to use it. And then PRESS, I think this is the bread and butter of of transplant, right? So something to look out for, especially if someone's presenting like a standard delirium case. I think they should have a low threshold to get a T2 weighted MRI. Okay, I think I finished. And those are my fellows, the ones sitting in the back. Questions?
Shall I jump in and then maybe we'll take a bathroom break or coffee break? Sure. So I realize that increasingly we're the only barriers between you and lunch. So I will only speak for about another 5 minutes. But I want to start off by doing a survey. You all learned that the average lung transplant patient lives about 9 years. Anybody think that is an unsuccessful outcome, or would define that as an unsuccessful outcome? Rarely do I get any hands to say yes. So now we're going to do an exercise where we're going to try to problematize what a successful outcome is. Because we were told that when Louis Krashansky got his heart that lasted 18 days, 1967, that was an unsuccessful outcome. Depends what you mean by unsuccessful. For Christian Barnard, it was very successful. He got to appear on the front page of the New York Times. His dating life improved, etc. That is a true story, by the way, but for a different day. So everybody, let's start off with 9 years. Everybody raise your hand. Everybody raise one hand. And I want you to lower your hand as these years become a not successful outcome. How many of you think 5 years for their heart or lung is not successful? 3, 2, 1. 6 months. I got one down in 6 months. 112 days. I will Shruti won. Why did I say 112 days? What is that a magic number from? Anybody know from medical history? 112 days is the number of days that Barney Clark lived with his artificial heart, the Canadian dentist, in the 1980s. It was a national news story every day. Now we would view that as very unsuccessful. At the time, the fact that this man lived 112 days was in some ways considered a miracle with an artificial Jarvik heart. So it also was relevant to time. So food for thought. That being said, there are a couple of key points I want to touch on. First, you made an interesting point about the difference between the role of the transplant assessor and every other role in psychiatry. Because every other role in psychiatry fits into one or two categories. Usually psychiatrists, most of what you do, is involved in the treatment of patients. But what I do, for example, in a forensic role, is in the evaluation of patients. The duties do not overlap. I tell the patient, I am not your treating physician, I am just an evaluator, sort of like an insurance claims case. In many transplant services, the evaluator also becomes your advocate, sometimes becomes your treating physician after the transplant. So that relates a lot of complexities about dual loyalties that are worth thinking about. The second thing worth thinking about in the context of successful transplants is the enormous cost that heart and lung transplants imposed. I think the average heart transplant now costs about $1 million just at the initial, and then you have to pay for the pharmaceuticals that treat you later on. Think about that in comparison to how many flu shots or mammograms you might pay for and the inequity of that. On the other hand, I will tell you it's a challenge between visible victims and invisible victims. If you don't pay for solid organ transplants, which Arizona stopped doing briefly in 2011, you will get people who need hearts and livers on the steps of your state house demanding care. If you don't pay for someone's smoking cessation course and they have lung cancer 30 years later, they don't think of themselves as a victim in the same way, which relates to our concept of Peter Singer and sort of this not just altruistic effective altruism, but also this utilitarian concept of some duty to larger people. We actually don't take that to the extreme. Obviously, if we carved up several hospital administrators, we could give out their organs and save a lot more lives. We don't do that, despite my strong recommendation in its favor. So clearly there is a balance. But finally, I think the most important thing you raised is the concept of capacity, because this whole discussion that we're having with a patient is really figuring out whether they meet some artificial threshold of understanding. And I would suggest there are a couple of problems with this. First, if anybody's read, for example, Omar Mirza's work at Harlem, the concept of capacity is deeply problematic. There are inherent biases, some of them racial, some of them socioeconomic, in the very way we assess capacity. Because many people can tell you exactly what they want and can't explain to you why, and that may apply very much in this situation. But beyond that, you actually mentioned several specific flaws with transplant. One, you can learn how to game the system. If there is no established database for people who were evaluated, you learn what you need to say at one center, and then if you're well-heeled, you go to a different center and parrot back what you're supposed to say, and suddenly you have capacity. But secondly, there's no meaningful equipoise, because for a large percentage of patients, they will accept any theoretical risk, because the alternative is dying. So the example I like to end with in this little chat here is I want you all to picture that you're a duck. Take a second and picture what it's like to be a duck.
A duck?
A duck. Quack, quack. I'm going to suggest to you it's very hard to imagine what it's like to be a duck because, candidly, you are not one. The problem is that being a transplant patient is about like being a duck. You are not one until you get the organ, and suddenly all the risks and all the concerns change. What might be either too high or low risk before the fact feels very different after the fact, either that you're grateful to be alive, or suddenly you have this enormous burden that you were not expecting before. And I will stop there.
All right, so we are going to take a little bathroom coffee donut break, and we're going to start back up in about 10 minutes with a really interesting talk on alcohol and liver transplant with Dr. Shenoy. So also, I didn't introduce myself because, again, my brain wasn't done before, but I'm Claire Brandon. I'm the SLP president. So if you have any questions or comments or thoughts, happy to take those also. All right, see you guys back in about 10 minutes.
No, we have time. Yeah.
What's wrong? Yeah, we'll get started. Okay, guys. Well, welcome back from your coffee and donut and bathroom break. And just to give you, highlights of what's to come, Dr. Shenoy is going to be talking to us about alcohol and liver transplantation. And then we're going to have some time for questions, and we'll sort of check in on the timing. But we have some interesting case discussions to also talk about to get a little practice with putting your mind in the transplant psychiatrist role. So just to introduce Dr. Akil Shenoy, I had the pleasure of having him as one of my attendings when I was in fellowship. And he is an expert in liver transplantation. Learned a lot, and I'm sure I will have to relearn it now in his lecture. So without further ado, I will bring him up here and put up his slides.
Thank you.
Yes.
Thanks, Claire.
Of course.
Always lovely to work with you, Claire. And it has been a while, right?
I graduated in 2018.
Yeah. All right. And I was remembering all the fellows. One of the so just to sort of riff on a couple things. First of all, keep your we're going to be asking you guys questions in a bit, like what do you want to know about, and how do you want to do this? If you want to do this in your future career, how can you do it? But so I'm going to go off of what Jacob said as we were leaving, is this idea about risk assessment. And so we're going to touch on this in this talk a little bit, but this idea of whose risk, right? From the patient's perspective or from the clinician's perspective. So we sort of balance those two risks. And, I was thinking about actually so when you were talking about donation, I was thinking about Aryeh. So Aryeh Dienstag was one of our fellows at Mount Sinai, a couple years, I think, before you, Claire. Yeah. And so he left fellowship and moved to Israel, and he started a donor, program there. And he just published this in AJT this year, December 2024. Great paper. And he showed that if you allow community donation, that means directed donation to your own community member, someone altruistically, that you not only increase Jewish donors to Jewish recipients, but you also increase Muslim donors to Muslim recipients in Israel. So you have both boats rising together, which was an interesting finding, which was not existing before. So it was like a new access to organ donors. So that was kind of cool. I was thinking about Aryeh. And then I was also thinking about, I think Nishi's talk was an incredible overview, and I'm so thankful that you kind of covered a lot of the nuts and bolts. So my boss at Columbia is Peter Shapiro, and he was doing heart transplant evaluations back in the 80s. A lot of wisdom, he's like my mentor, and he's able to sort of show me what, the ropes and how to do things. And I think homage to him, but also we are potentially getting, a line to get a transplant psychiatrist in heart. So, if you're looking for a job, look at us, okay?
Or a heart, for that matter.
Yes. But I'm going to be focused on liver transplant. That's mainly what I do. And And, I just have we have a 10-year grant studying this. But this really came out of my work at Mount Sinai. When I just out of fellowship, I was actually interested in lung transplant because that's what I did in fellowship. And then I came to Mount Sinai and they said, no, our lung transplant program is closed because we do very few lung transplants here now. I mean, it's now reopened. Obviously, they're doing many, many more. But at the time, I was like, well, you could do liver. So I did liver. And it wasn't my choice, but I got into it, yeah. And so the interesting thing was in 2011, this paper came out. And then in January 2012, we had a patient who sort of met this early listing criteria that was described in this paper, where patients who were drinking up until their first acute decompensation of alcohol-associated hepatitis were being considered for early transplant listing. So we actually did transplant this person, and they did very well. So that got me excited about then. And then I got called into the office. The surgeon came and said, let's talk about this. And he said, this is really important. This is something new. You should really put your efforts into this. So that really got me encouraged to keep doing this. And that's kind of where this started for me. So, I mean, let's just be clear, alcohol doesn't just cause liver disease, but it is the major reason why we work in this field. If I can prevent more liver disease, that'll be critical. But there are other issues, right? I mean, that are related to the rest of our work in psychiatry: suicide, homicide, toxicities, dementia, heart disease affecting other, systems, I think is important. So, but I mean, getting back to our work in liver transplant. So what happened was we started studying this, and we started to say, okay, well, if you look at a bunch of centers that are trying to do this new novel approach, the outcomes are not bad. And I hope Jacob is not going to tear this apart. But basically, the idea is that, your survivals are good, and the alcohol use after this type of early listing isn't so bad. Right? So there's a lot of selection going into this. When we first did this at Mount Sinai, we were only clearing about 25% of the patients that were coming forward. So 75% were getting not cleared. So a lot of selection. And in here, the same paper by Brian Lee, who's at USC now, what we found was that the major contraindication was psychosocial. So a lot of pressure on us, on psychiatrists, psychologists, and social workers to sort of clear or not clear these patients that were coming for early listing. And we're talking about patients that are newly admitted, potentially withdrawing from alcohol, sometimes very sick, well, oftentimes very sick, but sometimes a bit encephalopathic. So a tough patient population to see, but I'm going to get into this. So the goals today in this talk are, I've got a few myths that I want to dispel so that maybe teach you guys. And then I want you to sort of understand what a possible role for a transplant psychiatrist in liver could be, and then how to collaborate more and do the liaison, I think, in specifically liver transplant. So myth number one. So less than 6 months of sober time is a risk factor for death or graft loss. So I'm going to fly through these articles. This is like way back in the 1990s when this first started. They found that transplanting patients with alcohol-associated liver disease had the same outcomes as other conditions. Okay, so then we moved on and we started transplanting people with alcohol-associated liver disease. Now we're looking at these patients that were transplanted early. Well, the same outcomes as those who had 6 months and over of sobriety. Their outcomes were better. And part of it is because they're a younger group. These people with ALCAP come in, they're younger. I mean, this over and over and over again, I don't want to belabor this point. There's a lot of these kind of examples. One thing is we're interested in relapse rates. So the other team members are also interested in relapse rates, but their major concern is death, right? Death post-transplant. So moving on to myth number two, this is a thing that our liver colleagues, have yet to sort of come to terms with. Greater than 6 months sober time is the best predictor for ongoing remission. So, you get these stories where they make 6 months and they just, on the day, they're like, okay, let's put them into transplant. So they're like somehow magically then protected from relapse. So I want to talk a little bit about what the work I do. And part of this was actually with REA, looking at scoring systems and trying to understand, is there some way to predict? Are there categories? And Nishi over at Northwell they have their own. Actually, HALT is on there too. That's their scale. There's SALT that Brian Lee came up with, the SciPat from Stanford. All these different tools that are being used to potentially try to predict relapse risk, right? So the problem is that our staff, they're not actually familiar with all these. Some of them are, because the hepatologists who actually generated these, they're saying, well, let's take psychiatry out of it or take social work out of it. We'll generate our own tools. So the SALT was kind of one of those, because they're already using tools in transplant. This is actually, I think they're borrowing from our literature, because this is now, they're interested in looking at, like Anishi showed you some really nice survival curves, but even within liver transplant, there are patients that are going to do better and patients that are going to do worse. And are you going to apply these criteria? I mean, we know age is a factor. We know how sick they are is a factor. We know BMI is a factor. These are factors. So yeah, we're starting to do that in the rest of medicine. And because we've already been showing it actually, and Peter Shapiro, my boss, was showing this in like the 90s, that it was possible to show this kind of spread with psychosocial factors, right? So we are encouraging our staff to screen even early, even before they're ready for liver transplant. Or how much are they drinking? Is this real alcohol-associated liver disease, or is this met ALD, or is this not ALD at all? They've been using some of these scales to quantify. I don't want to spend too much time on this, but there's a lot of these they're basically scoring systems. And what you find out of them is that they're good, but they're not great, right? So really good negative predictive value, meaning a low score is good, meaning that's a potentially patient that's low risk, and that's good. But positive predictive value is awful, right? You can't predict the people that are going to relapse with these scores. So we wrote a nice little editorial on like low salt, right? Low salt is good for a transplant, right? So that's kind of what, so if you have a low salt score below 5, it's great. Okay, fine. But you can't say if they have a score of, because a lot of patients with a score of 4 or 0, they still relapse after transplant. Why? They lie. And that's where we're going to get to. Okay, so because that's what we looked at, like these initial Mount Sinai patients, the one that did die in our initial group that we studied totally lied to us, and that's why her score was so low, right? So, and we've actually even tried to use artificial intelligence. Would love to hear Jacob's opinion about this. Taking a whole bunch of tools, and taking a bunch of scoring systems, a bunch of variables, and just dumping it into machine learning and seeing what. So some interesting things happened. It's like, oh, did the patient have good eye contact with the clinician? And so that was a risk factor, poor eye contact, which we don't, I mean, I've yet to go in front of a liver transplant committee and say, this patient had poor eye contact, so they are not allowed to get a transplant. But these are the features that came up using artificial intelligence. So I guess the myth number 3 is, so these scoring systems alone can't predict, right, AUD remission. So what can? This is where our work is so important. We're in that space, that small space where we're in that room with that patient, and it's just us and them, and you have to figure out what's real and what's not real. And I want to just take one issue with what Jacob said before. Everything else was perfect. But one issue is that it's not just what the patient says, because we did write the paper on second chances and patients that went from one hospital to the next hospital to the next hospital, and they kept going around. And they did learn some things. But we have Epic now. So you can always look at what they did at the other hospitals, and we can see their history. And history matters, because you have to actually help the patient reflect on their own history. So kind of understanding where the patient's coming from. I use a kind of technique, and I like this because, I love the biopsychosocial model, and I was trained with biopsychosocial, but I think since residency, I like the perspectives model. Anyone know what perspectives are? And raise a hand if anyone know what perspectives are? Okay, from McHugh, Slavny, Hopkins. Okay, so if there's a Hopkins person here, you did residency at Hopkins, you'd be like, oh yeah, I know, explain the whole thing better than I can. But basically, if you're a Hopkins grad, you know perspectives. It's a whole book about how to do basically the biopsychosocial model, but in their way. And it's a very unique to their, look, they've been doing it for many years. But the idea is, it's the acronym is HIDE. So H is the patient has some sort of disease, right, or disorder. So this is the medical model. That's the medical perspective. So they have a brain disease in this situation, right? And then you've seen this picture before. This is, the George Cube, the medical model of addiction. But the other perspective, who is the patient? What's their personality? What's their background? What's everything else about them? And then the third model, or the third perspective, is what's their behavior like? And this is actually probably the most relevant to addictions, right? Because it's not just a brain disease, it is a behavior. And you have to understand it as both a brain disease and a behavior. Because if you ignore the fact that there's, in Saudi Arabia, we don't have AUD, right? So because it is about how it's expressed in their environment. Is this the first encounter? And this is the sort of the crux of the perspectives, is the narrative. Where's this patient coming from? How are they presenting now? And that's the meaning that we all love in CL, because the story is what brings us to this patient, right? So I'm going to kind of lay out my talk in this way. So first of all, the patient has an addiction. They have binge and intoxication. They have withdrawal and negative affect. They have preoccupation and anticipation. These are the features that they have, right? Who is the patient? What are their strengths? What are their weaknesses? This is the stuff we love to talk about. Who are they? Do they have a personality disorder? How do they cope? What are their defense mechanisms? Are they problematic defense mechanisms, or are they beautiful defense mechanisms, right? What's altruism? You learn that altruism is always beautiful, but wait, it could be conflicted. Go back into, Anna Freud, there's a lot of problematic altruism out there. Comorbid psychiatric problems, and then comorbid substance use. We do know that those are huge factors that predict relapse, right? Polysubstance abuse, tobacco use, comorbid psychiatric issues like PTSD, cluster B personality, these are predictors of relapse. So you always have to think in terms of Skinner, right? So behavioral, what are the reinforcements? What are the punishments of drinking, right? So what is the patient doing that makes them more at risk for ongoing use? So this is another way to think about it. And then their encounter. And this is actually really important, because in Dallas, we came up with this consensus document, which is basically, what are we going to say is allowable for these early listing patients? And the basic consensus was, this is their first episode, right? And we as psychiatrists became actually, at this point, we became I think, the best equipped to understand someone's first episode. Meaning, we discovered patients' prior through our history taking, we would understand things that the hepatologists missed because they weren't taking that detailed history. We were learning that, oh my God, this person has been hospitalized before for this same condition, and they kept drinking afterwards. They're not eligible for this early listing criteria. And that's something that, that's a lot of conflict there, but I'd love to talk about it more. But that has become our rubric. Is this the first encounter? Is this the first time? And actually, this kind of helps feed back to, if anyone goes to any doctor, hepatologist, a primary care doctor, anyone, earlier you're on, I mean, we're talking about now primary prevention, what should they do the first time they see someone that has signs of liver damage and they're drinking? And how should they ask the questions? And how, because we see so often in their history, oh my God, they just said they didn't do anything for me. I mean, again, this is like part of the patient's story, but they didn't offer me any treatment. They didn't offer me any, there was no, no one from social work came, no psychiatrist came, and I never knew that I should stop drinking, right? And this was like 6 months earlier, a year earlier, or 10 years earlier. So how can we really use that moment, right? So what I do is, and I'm happy to share this with you, I have like a whole cheat sheet about what I do. I love this question because sometimes we're like, wow, I didn't know. I was like, you really didn't know that alcohol could damage the liver? Like everyone knows that. But anyway, these are the kind of, it's an hour that can be sometimes tense, but it's good. In the end, if you can sort of come to terms by the end of the hour with something that the patient says, okay, I'm grabbing on to something that you're saying. So what I usually do is get the history, and then I actually go through the DSM criteria with them. So I just read out the criteria, and I want them to be able to connect with these sort of features. If they had told me in the past that they were having, they're struggling with the drinking, or they were their spouse was having arguments with them and fighting with them, and they were trying to get them into rehab, and yet they cannot connect that part of their story with the DSM criteria, I say, wait, there's some sort of disconnect here. You think you know, but you don't. There's some lack of sort of consistency. So that's what I kind of do through this. And I, if I have to, I also, I go through the withdrawal, the affect, the craving, and all those features to sort of say, can't you connect to any of these things? So that's where treatment comes in. That's where medication, I'm not going to spend too much time on these slides, and it's the medical model, right? We have now a test for the medical model. We have, just like diabetes, it's a chronic medical condition. Alcoholism, we can argue about this, but it could be considered a chronic medical condition where you have a test to say, your A1C is too high, let's bring it down, right? Direct biomarker for it, and it's now, it's very popular, getting more popular. We have cutoff scores. It's all a whole thing. We reviewed the other risk factors. The grant study showed us that there's protective factors. There's a lot of stuff out there. So I asked, what are they doing now to change their life? Because they need to sort of change everything. They have to sort of alter their friends. They have to alter their day-to-day activities, their nutrition. Everything has to change. So what are they doing new? But I guess this is the point, this encounter, that first thing is the teachable moment, right? That's where you're in the hospital. It's the first time they're kind of wakening up. And this is, you don't have to be on ketamine or anything or they're a psychedelic to understand this. They're sick and they're like, oh my God, I have liver disease. So that's your teachable moment. That's when you deploy this to get them to treatment, right? And they have to be, there's this sort of thing about the, where are they in that ability to absorb, right? Are they too stressed out for this conversation? Are they not stressed enough for whatever reason? Are they encephalopathic and they can't have this conversation? I mean, that's the question, is how can we assess their insight? I go by what, I don't know if you guys have this. Anyone ever tell you to follow the affect?
Yeah.
Oh yeah? Where? Who?
It's like a dynamic supervisor.
Yeah. Follow the affect. Learn, yeah. So follow the affect. So what do they say when they're emotional and they have affect? Maybe they're not emotional. Maybe it's not crying or anything like that. But they're telling you they're distressed. Their words are saying they're distressed. What are they talking about in that context of feeling distressed? Do they just want the nurse to come bring them something, an opioid? Is that what they want? Or is there something else that they're distressed about that you can connect with on a bigger scale, right? This was a wake-up call. I have an addiction. I need to do something else with my life. I'm an alcoholic. These are the words that I'm trying to get them to, I'm trying to hear it, but I'm also saying, wait, I mean, isn't this part of it too? Like, isn't this also something that you're distressed about? So, I kind of come up with a treatment plan. I believe in medications for this. But it's mostly self-care. It's mostly nutrition. It's mostly doing things to get their feeling better. There's a lot of levers to push that can help them, reduce their risk of relapse, right? So you're talking about in the first week, the first 2 weeks, the first month after stopping drinking, what kind of levers can you help with to reduce their risk of relapse? And then encouraging ongoing help, right? So it has to stay fresh. They talk about it in addiction literature as staying green, right? You have to remember that you were sick, that you don't want to go back to that. And that's where the teachable moment is like, it's going to be an ongoing thing. It's not just in the hospital. Don't come back to the hospital for this because it's going to be an ongoing thing. Anyway, so this is where I wanted Jacob's, and I'm sorry, is Peter still here? Yeah. Oh, okay, sorry, yeah. I'll say AKA the Odysseus contract, Peter. So the Ulysses contract, though, is this idea that, Ulysses was like, I can't deal with this. I need help, right? And I want you to help me, and I want you to help me with my future self. So this idea of you're going to help them. If you don't remember the story of Ulysses or Odysseus, he tied himself to the mast and said, "Don't let me go," okay? And he told all his people, his seamen, anyway, his compatriots. They was like, he told them, "Don't let me go," and then he was up there and he was stuck and he was like, and then the sirens were calling and he was like, actually, can you let me go? Let me out of this. Just for a second. I need to get out of this. And they said, you told me, boss, don't let me go. You told me not to let you go. So this is the idea is like, can they get a commitment around whatever you're proposing to them? So what I'll end with this. It's like it's 5 minutes. So liver transplant and advice, right? And this is the high tense situation where the patient's super, super sick. They have a high MELD and they've not been sober for very long. And you're being asked as a transplant psychiatrist to clear them or not clear them. And you're under pressure. And in your mind, you're thinking about risks and the patient's thinking about their own risks. All right, so what we did was we looked at from 2020, 21, and 22, so 3 years, 256 recipients. So 101 were alcohol. So that's like 39%. So the leading indication for liver transplant is alcohol, right? So, but we wanted to look at those high melders. So those are like melds over 25 that we were doing an inpatient psychosocial evaluation, and there was less than 6 months of AUD remission, and there's 42 that fit that criteria. And then one actually died, never left the hospital. So I'm looking at 41 post-transplant patients that we followed for the last 2 to 5 years, and 19 relapsed, right? So they were using PEth data. So even if they had a small PEth, we called it a relapse. So any PEth that was positive. Most of them were okay, but I'm going to talk about the 2 that died from relapse and the 7 that has some liver damage from the relapse, right? So here's the thing. I went back and looked at my own risk categorization. What did I say was high risk and what did I say was moderate or low risk? If I said they were high risk, 15 out of those 21 relapsed. And then if you look here, they relapsed very early, like within 6 months of after transplant. This one died. These 2 heavy drinking. This one died. So again, within a year. So that was actually eye-opening for me. I was like, okay, it kind of felt like this was happening, but it's like, okay, well, there are a lot of patients are actually relapsing, and we've tried to mitigate most of them. But if you look at the moderate risk, they didn't relapse as early, and most of them were like really low-level drinking. Only one had some sort of damage to their liver, so that I'd said was moderate risk. So what, I have to go back and now like try to understand this and sort of so the SALT score didn't predict it, the HRR score didn't predict it, but we have to look at all the other parameters, and we're probably going to use artificial intelligence to try to understand how this came. But the odds ratio was really great, so I can feel like I can say, listen, it was high risk, and you should pay attention to this. This is what could happen. And we could sort of, I know what my liver colleagues will say is like, well, why don't you we're doing this already, but why don't you just take care of these patients? And we have to. These patients in the first 6 months after transplant, maybe we could do something more with those patients. And that's going to be, that's an ongoing work. So that's a question for me. I looked at the Accelerate data, which was all these 12 centers, and it's very similar, right? So you have this group that they relapse early and they have heavy drinking, frequent drinking, and those are the ones that die. Their probability of survival was 50%. So I guess getting back to Jacob's question is like, what can we tolerate? Can we tolerate 50% survival in 5 years? Not even 5 years. This is 3 years, right? So if we can't, if your center can't, your center's like, nope, that's too high a risk, then don't do it. That's easy. Don't do this. You don't have to do it. But if you can, and you're a big center and you want to see more and more risky patients, then do it. But take care of the patients afterwards. So myth 4, only a psychiatrist can manage these patients. No, we need to figure out. So I gave this to a hepatologist. Now they're screening for all these patients before I see them. We have to operationalize the Dallas consensus. So having this social worker start to screen them even earlier, that's one idea that has to happen. And then the hepatologists have to get comfortable with writing prescriptions for AUD medications, which they are at MGH they're doing, and at Yale they're doing. I think at Columbia we have to start doing a lot more of, but it's happening, but it's slow. So I have a strategy for follow-up. I reuse Epic a lot, so I have the high risk patients I put into a pool. I kind of have a way of getting them on my schedule automatically, and then sort of they get PEth testing on a regular basis. So that's kind of how we do things. We're talking about this in a couple months with a lot of other people around the country. So it's going to be a nice conference. If you're interested in alcohol and liver disease, you can come. I'm sure it's free for trainees. So it's at the New York Marriott at Brooklyn Bridge. So yeah, so nothing else from me. I just wanted to thank you guys, Shruti for organizing, and Claire for organizing, and Nishi for talking. I think and Jacob and I'm welcome Jacob's now.
He taught me everything I know. I forgot most of it, but still. So, no, I really appreciate that. At this event you're having, by the way, are they serving alcohol? Just checking. So I do want to begin by asking you all a question that will not appear on the boards if anybody feels brave. What are your lifetime odds of being struck and killed by lightning in the United States? Anybody know? Give it a good shot. 1 in how many? You're not bad. So it's actually about 1 in 16,000, but we're well within the right magnitude. So when I was, I think, 12 years old, I was in the beach one day during a lightning storm, and my mother got very upset at me, and she called me back in, and she said, "You're going to get yourself killed." So what did I do? This is the era before the internet. I called the public library, and I said to my mother, "The odds of me getting struck by lightning are 1 in 16,000. And my mother said, "No, they're not. They're 1 in 2. Either you get struck or you don't." And there's a lot of wisdom in that, because for the individual patient, it's either you relapse on drinking or you don't relapse on drinking. And it applies in the same way, by the way, to life expectancy and these cases. So if you're diagnosed with, ALS, and you go on the internet, the first picture that comes up historically was not that of Lou Gehrig's disease. It was actually that of Stephen Hawking. And everybody thinks they're going to be the tell. Everybody thinks they're going to be the exception. And that's the inherent tension, because Akil, Dr. Shinoy, is talking about risk today, talking about prediction today. The prediction is an aggregate, and the patient is an individual human being, which is why there are a couple of other issues that he raises that are problematic. First, he says, well, everybody knows that alcohol causes liver disease. So my great-grandmother grew up in a small village in Lithuania. She came to the United States in her 40s. She never learned a word of English. She never had a job. I doubt she knew she had a liver. For a large segment of our population, things that seem pretty intuitive to us are not intuitive at all. And I will add, by the way, if you want to have fun, it's like a party, a dinner, a cocktail party, game of cocktail parties. People who know a lot in non-scientific worlds know much less about the body and science than you might think. For example, if you ask people, I've done this, to explain Darwin, about half of educated people will explain Lamarck. And if we ask them to explain a lunar eclipse, some of them explain to you how the Earth slides between the sun and how the sun slides between the Earth and the moon, which clearly doesn't happen. So asking people to understand causality in medicine may be a really high bar. Second thing you mentioned is that you're going to use AI to assess this. So the great thing about AI is if AI were unbiased, which means if the people who program the AI were unbiased, the outcomes you would get would also be unbiased. But all of these factors that you're taking into account, like eye contact, are heavily culturally embedded, and to be blunt, measure the cultural standards of well-off white people in places like Scarsdale, and then impose them upon I grew up there, so impose them upon everybody else. So that may give you an accurate result, but not a result that achieves the goal you want to achieve. It may measure something very different than what you're striving to achieve. A few more points to make. So you also raised implicitly the question of personal responsibility. To what degree do we care whether alcohol is a disease, and I assume nobody here would choose to be an alcoholic, versus alcoholism simply being a choice? And even if you believe it's a disease, to what degree does that discount you from the penalties of still relapsing? If you relapse in alcohol and you run over somebody's little kid, nobody says you can go scot-free. And for that matter, nobody would choose to be minorly attracted to minors, but if you go out and sexually assault someone's child, we put you in prison for a long time. And arguably, we well should do that. So just because something is biological does not mean it absolves one of any personal responsibility. It might, but particularly in a system where there's a trade-off and someone else's life is going to be taken. So a very concrete example of this, you probably have, during COVID, heard the case of Blake Bargatze. It was a happy news story in the world of darkness of the pandemic. He was a man in Florida who got a double lung transplant after getting COVID, and he survived. He had been offered the vaccine several months before and had turned it down. People talked about this wonderful miracle his life was saved. They did not talk about the two people, presumably, who had idiopathic lung disease or cystic fibrosis who died because they did not get an organ. So there's a meaningful trade-off here. Related to that, should your donor be able to know what your cause or the underlying reason for your liver failure is? What if I'm a cadaveric donor and I say, I only want to, if I leave my organ, to give it to someone who has a biliary disease, which is why they needed an organ. Will we honor that the way we would with a living donor? Right now, as a general rule, we do not. However, it's also worth noting to some degree the MELD score takes that into account, because we do give you extra credit for certain things, certain cancers, for example, that we do, metabolic disorders, that we do not view as a result of, at least in part, your personality or social responsibility, however you want to characterize it. Whether we should or we shouldn't is a different story, but that presumably is the underlying rationale for that approach. And finally, I will ask you the question for these patients who do relapse, who damage their livers. Obviously, even if they survive in the short term and it proves the alcoholic hepatitis study works, they may actually be at higher risk of relapse in the long run. And what will they need in the long run? Another liver. And the question is, in for a penny, in for a pound. You get one liver, and if you relapse, then after 5 years, after 10 years, how long do you clear the slate before you get another chance at a liver when someone else is still waiting for their first liver? And I will stop there because I could go on for hours, but this is that moment where some of you turn off your Zoom on the camera. So I will stop.
Okay, so we are going to have some question and answer for all of our excellent talks for a few minutes, and then we'll see what our timing looks like as far as doing some case discussions. But since some of you might have to pop out, at the last minute, I just want to highlight a couple of things that are coming up for SLP. On March 27th, aptly after Dr. Shinoy's talk on alcohol, we have a winter wine cocktail party. So keep an eye out for emails about that on March 27th. That's going to be at Vanguard Wine Bar on the Upper East Side. And we also have our annual dinner coming up in June, so keep an eye out for those as well, for those invites. And if you want to be more involved in the SLP, we are always interested in having new members on the board. If you want to have a say in what happens in the SLP and some of these talks and helping organize those, we'd be excited to have you. So feel free to email me or the SLP email address that you have literally been bombarded by emails from me with. So please reach out. But we could start, maybe I can, you guys can project your question. I can repeat it if they can't hear for the Zoom, and then the panelists can speak into the mic if you guys have questions. Yeah, go for it.
This has been great. I mean, we do. I'm Leslie. I'm one of the fellows at Mount Sinai. So we get a lot of exposure to transplant. I was interested if you could go more on about the idea of like that first impact when you're doing the evaluation and kind of like a little bit of motivational interviewing. Because one thing that we've been working on with the residents is they feel a lot of countertransference. It's like I want to help the patient, but I understand I'm kind of more evaluating them right now.
Yeah.
So is motivational interviewing something that can kind of be part, or at least maybe on a second evaluation for patients?
It's super interesting. Yeah. So, and the question is, right, the two hats we wear, right? You're taking care of the patient. I think if you're in a program like Mount Sinai or Columbia or NYU or Mount Montefiore, where you are leaning into alcohol-associated liver disease as a condition to transplant, because it's the most, common reason for liver disease, and you don't want to avoid this problem. You want to, we're not trying to encourage it by any means, but to get to your question, we haven't done a retransplant for someone who's relapsed, right? So yes, and I don't think so. So that's a good question, but I think the idea is that when you're with the patient, you are trying to get. We're trying to get to yes, right? So you are trying to use any and all techniques to wake them up from their hepatic encephalopathy so they can have a conversation with you. You want to get them to, as problematic as the capacity assessment is, or these types of interviews are, you're trying to have that conversation so that you can give them the best chance at access. So if they're in denial or they are, let's say, too stressed out, you have to come back. You have to sort of work through the denial, something where you are getting them to that optimal, whatever that Dodds-Yerkes curve there, where you're like, okay, you're in the sweet spot to have this conversation. We're actually there, and we're giving you the best chance possible to have that conversation. How much motivational interviewing can you do in that situation? Again, the goal is to treatment, so the basic bar is like, the alcohol caused my liver damage, but the next step above that is not only is the alcohol causing your liver damage, but the alcohol is associated with you having a use disorder or an addiction. So can you get to that? So encouraging them to get there. And then the next one is, now that you know that, can you accept treatment? So I think doing what's the basic techniques of motivational interviewing are, as I wrote there, it's really like rolling a lot of resistance, right? But being empathic and just listening to where they're at. If you can't get there, you can't get there, but you try. Yeah.
On a similar vein, though, that last step, I do need treatment.
Yep.
Obviously, treatment is important. Treatment helps, keep abstinence, but it can become, and I've seen this a lot, definitely outside psychiatry as well, like if you cannot do treatment, then this cannot happen. Because a lot of patients will say, well, I'm going to go abstinence, or I'll go to maternity, don't worry about it, or, that ambivalence there.
Yeah.
They're not wanting to do a specific type of treatment. And so I've definitely seen, well, no, that's not good enough. You need to do this.
Right.
And I wonder what your perspective on that is, how to navigate that, because on some level I do understand it, but that is, very much brushing against that coercion component.
Absolutely, and but I just wanted one piece, because some of these, we're talking about two different types of patients. One is the inpatient, where we have days, so there's no, and then we have to sort of trust. Are they going to actually try to follow through with what they're saying? But there's no way to mandate it, because you're only having these conversations before transplant. Afterwards, there's opportunities, but you're right. That's at that point, how do you mandate anything? But I think there are ways. I mean, I think you're right. There's some level of coercion, in the sense that even having a family member there to bear witness to the patient then now talking about their addiction for the first time is a soft coercion, right? They're now saying, oh, I have a problem that I'm having to face my demons right here. I'm already facing these demons in my body, and now I'm facing these psychological demons from like the 10 years prior. So, right, there is that. But I think in the outpatient setting, when you have time, having them at least try treatment and seeing what works and what doesn't. I mean, again, we're looking at the combine and doesn't match. These trials where they're looking at what is the best fit. You don't always get it the first time. You might get it the second time or the third time. We talk about AA, right? You might have to go to 5 meetings in different types of settings to sort of get your fit. Medication's the same way. But not doing it at all, saying I don't need it. Now, there are some people that will stay sober without any help. You don't know who those people are going to be right off the bat, but at least giving some attempt is worth it, because we do know that people that join treatment do better than people that don't.
Yeah, no, I have the number of thoughts, and that was very eloquently put. So I guess related to that, but also related to your question of countertransference, which I think is also a very important one to discuss, which comes up in recipient review committee meetings. So I think that Jacob alluded a little bit to equity. So I will say that, there is a whole separate conversation, as I mentioned, about the liaison element. Like, how do you fairly present the patient in a recipient review committee meeting, acknowledging that there are many players, many personalities, each of them have their biases. Like, there was a time when we actually noticed that there was a very strong bias towards people with young children. And I guess that's an interesting equity issue, right? Which means that if 2 people have the same risk profile, but one person has children, maybe that story tugs at the heartstrings more for people in the committee. But then at the same time, their risk profile is the same or maybe higher than somebody else. So there's the subjective, but also the objective. And then there have been some studies showing that, if the hepatologist who has taken care of the patient is actually in the meeting and they've known them, they sort of advocate more for the patient. So, all these things can result in bias, subjectivity, inequities being perpetuated for the same exact risk profile. So that's one thing to keep in mind. And I guess from the psychiatry standpoint, so psychiatry and social work at Mount Sinai, one of the things that we realized was that we have to be very careful about things in the story that are, very heartbreaking, how we share them. Because, for instance, once one of our social workers, kind of very sort of, in the spirit of being comprehensive and presenting the patient, basically said, so this patient who was exquisitely high risk, like had gone to rehabs, relapsed, all kinds of consequences, very severe alcohol use disorder, extremely high risk, and she said something like, well, this patient was assaulted by their uncle at age 11. Now that is a horrible thing, but it is also a vulnerability. And it's also something that, if that is tied into the alcohol use in some way, may not be fixable overnight, right? And this person is very high risk. But as soon as that was presented, one of the hepatologists basically said, can you imagine that? How can we let her die? Like, she was assaulted at the age of 11. So I think that, I used to, before I did transplant work, I used to always think that, well, psychiatry is subjective, but medicine is objective. And I don't know if I believe that anymore, because I feel like psychiatry, we talk about our feelings so much that at least we're aware of when they are impacting our decision making. Whereas in medicine, often people are not in touch with their feelings, and so there's wild emotional reasoning. And, to your point, I think, and just what Amrit said, I think, there's obviously like medical criteria for listing and psychiatric criteria. And if somebody, with acute alcohol-associated hepatitis, I think the reason why, the door was open to expedited transplants was because the prognosis was very poor at 6 months. But with cirrhosis, actually, people have time often until they decompensate. So the thing is that if you do have time, or if somebody is dischargeable from the hospital, then sometimes you can make a case for, and comfortably, like without much moral injury, yeah, this person has time, let's just, let's have them engage in relapse prevention, work on their insight, do all the great work of motivational interviewing, etc. But I think the problem occurs when they don't have time. And then it really becomes sort of this, like, how can I, say this in such a way that definitely results in the decline of this patient? And the team struggle with that as well. So that's like an important thing to come to. And I don't know if you wanted to.
Yeah, I have a couple of thoughts. One, I want to emphasize the equity issue, and particularly you mentioned, for example, if you have a long-term relationship with your hepatologist. That does not come out of the blue. Every element of equity builds in another element of equity. But the second thing I'll make, there were many problems with the God Committee at Swedish Hospital, which basically viewed people based on their social worth. But there was one aspect of it that I actually think was an advantage that we don't do today. When they reviewed these applications, they did not view them in a vacuum. They had to look at all the other people's files they were not giving dialysis to. Now, obviously, they did it in an overtly biased way. But I think if transplant centers had to understand who they were not giving kidneys or livers to, it might make them rethink a lot of their perspective and at least undo some of this bias.
Yeah. Who are we declining and why?
It would make you more aware of why and your own biases in a way you're not.
I guess, sorry, not to belabor the part, because I've seen where it's like, maybe this person is like a single parent, and their idea of like their social support, they're still the main breadwinner, but they have a lot of friends or whoever else who is support versus someone who might be married or has a little bit more, then that's weighed a little bit as in a way stronger social support. That's like how much of that is kind of our bias in that.
Well, absolutely. Yeah. I mean, it is not lost in us that doctors on the whole, whatever your background and experience, are normalized to certain social constructs, and you bring those to your expectations of patients who may have extraordinary forms of resilience that are completely blinded to you because you come from a different world.
I have a question for you guys. Well, I have a two-part question. One, I'm thinking about a patient that I see, outpatient, who has, I would say, alcohol use disorder, but is not interested in stopping and has no issues with her like medical labs at this point. We talk about it all the time. And in the back of my head is, how much do I write in this person's chart that's going to prevent them in the future from getting a liver transplant when inevitably they probably will need it because they continue to do damaging things? And so I'm just curious about your thoughts, like both from a medical standpoint and ethically. And my second part to that is, I actually didn't know that the PEth was a thing that they were monitoring in people now. And I'm curious how much you think either psychiatrists should be regularly checking that in people to start the conversation early, / does that hurt their chances in the future of liver transplant? And maybe that should be something in primary care as well that gets started in a conversation to be trying to protectively talk to these patients ahead of time to give them a chance at protecting their livers.
So two great questions, Blair. So
you.
first of all, so talking about the potential for liver transplant and doing things now that could benefit their chances in the future, it's kind of like saving your kidney for someone in the future. I actually think you got a patient in front of you now. Take care of them now. Mm-hmm. So 2 points to that. First of all, FibroScan, more technology, right? So get them. I know the LFTs are normal, but maybe they're showing some fat fraction on their liver. So if she really wants to know if her liver is well, it's basically an ultrasound. It's not invasive. It's easy to get. So that could be, and you could even pay out of pocket if insurance doesn't pay for it. So it's like $100. So I think that's one way to sort of test her. The other thing is use the PEth now, not just for are you drinking or not, but how much are you drinking. So we're trying to correlate the PEth level to like the WHO standard for which is heavy drinking and problematic drinking to the liver. So if you could just drop her from that sort of high risk drinking down to a lower risk drinking, that could change her odds quite a bit. So I mean, I can give you the number. I mean, you're talking about like a 5-fold decrease in risk if you just go from like the highest level to the middle level, and another 5-fold if you go from the middle level to the lower level. So just reducing the amounts can be helpful. So the PEth has value there too.
Yeah.
I actually did have a thought about because when we do our evaluations, we always talk about, as Jacob and I had written this paper about the psychosocial database, how now that we have an electronic medical record and care everywhere, it is important to see if there were other evaluations. We actually scan the notes to see in care everywhere, is there any documentation that alcohol use was discussed, alcohol cessation was recommended, resources were provided. So I think it's interesting because I guess if you write nothing about a discussion about, alcohol or anything, that could in the future, I guess, help the patient because we won't find anything saying that, no, doctor writes, we had an extensive conversation where I, explored alcohol use, gave resources, patient declined or something like that. So I guess you could say things that increment, like that increase the risk assessment in the future. But I guess if you say nothing, that can help, but you should also appropriately document. But I guess what I'm saying is that there is something to be said ethically about even when transplant is not on the table, like how much should I say or not? Will it hurt? Will it not? Can I just be objective? I don't know if you want.
I can actually,
For the record, for PMS who's listening, I do document this and talk about it with my patients. She's on naltrexone.
So I didn't. Yeah. So what I
was
was saying
kidding.
that you can always state very strongly. Like you can write the bare.
But would you
minimum
subpoena the
issues.
records? Like, how do you get their? Like, I'm not in Epic, right? Like, how do you get these records?
They're gonna call you.
Yeah.
And they're gonna say, "What did you do?" And you're gonna on the spot. You're gonna say, "I told her to get treatment." And then there's
or you won't. I actually agree with Akil in the sense that your job is not his job or the transplant committee job. Your only job is to advocate for the patient. Now, you need to make your judgment what's in the patient's best interest, whether it's to document this or not documenting this, which is a different question. But otherwise, you could take this to the extreme. You wouldn't document anything. You wouldn't document the patient had a legal issue 30 years ago because even though it's relevant to their psychiatric needs, it might be held against them in terms of bias or presentation. We don't, in the community, apply the standard in any other way. We don't say, it seems like you have a bacterial infection. You'd probably feel a lot better with an antibiotic. But I also know conceptually that antibiotics are being depleted. We're building resistance. So I'm going to see if you can, beat your memory on your own. And if you come back on the ventilator, then I'll give you some antibiotics. We don't think that way in any other context.
I guess for that particular scenario, I would say actually documenting can also help because we've utilized it to actually formulate a treatment plan. So we're very aggressive with use of MAT very early on. And so we actually stratify like how severe their alcohol use because all the patients withhold information. They minimize their alcohol use. Obviously, PEth is a good snapshot, but it takes it takes a while to kind of populate for us. So we actually stratify according to their relapse risk and stuff like that in terms of what we should initiate. So we start them on naltrexone right away, and then in conjunction with like bupropion, we have like our own little protocol. So it might actually help them in the long run to formulate a treatment plan because most of our ALCAP patients are high risk, and we know they're going to relapse, and we still transplant. So
I'm going to put Shruti on the spot. Can I ask a question? So knowing what you know about equity and what we've talked about, why do social evaluations at all? Why not simply have some very hard markers and say the rest of this is just bias that is going to outweigh any benefit and not bring it in?
That is an interesting question. I guess what I would say is, I haven't thought of it in quite that extreme a way, but I will say that, I do think that psychosocial, I guess to say that, we should do away with the psychosocial evaluation is like saying that it's all just these criteria and that's all that we look at. But I think that there's nuance to the criteria. There's like a context to the assessment that goes into, and plus I will say that, the social workers and psychiatrists, so social workers, for instance, like let's say with social support, they may not only say social support or not, they do a lot of legwork in sort of like, contacting the person's fifth cousin and, if there's nobody around, etc. And we actually had a case recently where I think there was no obvious support, but the social worker actually did a lot of groundwork and, work and was able to sort of, get in touch with some people and then establish like what's the functionality. So I guess the first thought that comes to mind is that I think that the criteria, there's a lot of layers to it. So for instance, psychiatric stability. So in terms of the role of the psychiatrist, I think that there's nuance to this. That this is where, psychiatry skills come in. Like, what do we mean by that? Does this person have an untreated mood disorder or PTSD that needs treatment? So I still think that there is a role for assessment and treatment in terms of like clinically helping the patient. But yes, there are ethical issues with it.
Yeah, food for thought. Just to play the devil's advocate, you could bifurcate those roles and say, obviously, a psychosocial is valuable for building supports for the patient, but it's independent of the evaluative role for whether or not we do the transplant or not. And that everything that the art form is independent of those markers is really us imposing our own biases. The patient comes in and says, well, I spent 6 years in prison. And most of us say, well, that means that's problematic, not you're resilient.
Yeah, we're doing that already, right? In the sense that social worth is not social support, right? So someone who's employed, who's supporting others, we just denied someone the other day who was doing a lot of good for his family, but he wasn't meeting our criteria.
But I'm suggesting that social worth and social support bleed into each other very heavily. Because we've all been at these meetings where someone says, oh, but she's the daughter of a doctor. And suddenly the conversation shifts entirely. Or nobody says it, but someone says, oh, she's white and upper middle class.
It's very helpful to have criteria. It's incredible. So this is, and these types of, you get a lot of arguments in the meeting when there's where social worth seems like it's in the room. And then there's going to be back and forth between the various clinicians who all see a different side to this. And yeah, I mean, I think it's proven that having some sort of criteria for that will be beneficial. But you're right. I mean, we're all people, right? In the end, we're human, and we get swayed. And then, but at our center, the thing is, if we say, well, they don't meet our criteria, we're not going to change the criteria on the fly for that one patient. We're going to have a meeting about it and discuss. Again, let's look at the data. Let's look at all these patients. If we're going to change the criteria, we'll do it in a measured way.
I'll offer one more theory. Actually, I don't know if anybody does this, but the ethics committee presumably has community board members on it. The IRB presumably has community board members on it. Do the transplant review boards have somebody or people from the community that say, you're seeing this differently? And maybe they should.
Yeah, I guess I also have so I have two thoughts about this. I mean, one is, I guess, for the audience, like, because this is where I think, as Jacob mentioned, bifurcation of roles. And I guess the one thought that comes to mind about that is that, when you're a forensic evaluator, right, let's say competency to stand trial, you're not the treating psychiatrist. So there's a very clear boundary there. But I do tell my fellows, when we do OLT evals, that there is a forensic quality to our evals because we are trying to sort of, we are being empathic and motivational interviewing, but we also have to do this risk assessment and risk stratification and be stewards of this limited resource. So I guess in terms of blurring of those boundaries and the bifurcation, do you think, like in organ donation, right? Suppose a living donor comes in and says that, I'm like 80% sure, but my relationship with this person is also a little bit complicated, so I have some doubt. So ambivalence, we know that's associated with that outcome, and we generally sort of, recommend therapy. Do you think that the living donor psychiatrist should be the one saying, okay, I'm going to put you on my calendar for 10 sessions to work through your ambivalence? What do you think?
It's a great question.
Should you, as the living donor evaluating psychiatrist, also be the one doing that therapy? What do you think? No. How so? No, and then that's a great point.
Like if you're doing therapy with this person, your counter-transference is very positive, you may hinge your decision based on, or really negative, you may hinge your decision on their eligibility based on wanting to protect them from making a decision you think they'll regret versus putting them forward when maybe they're not as appropriate.
Yeah, that's a great point. So I guess one argument would be, even though I hate the term like gatekeeper role, in a way you do play that role. Like if this person is ambivalent now, but they come back a year later and tell me I'm 100% sure now, I've resolved all my conflicts with this person, this is and makes a very convincing case, I am going to be the one saying, okay, we can proceed. So isn't there a conflict of interest if I'm the gatekeeper for me to also sort of work through that conflict and get them either ready or not ready? So I think that there's that piece. But then I guess we can also ask the flip side of this. What if you're doing like a recipient evaluation and you see somebody for, let's say, a heart or a lung, and they have a lot of anxiety? Should you then say that, no, I'm like the gatekeeper for this transplant, so I shouldn't treat their anxiety, somebody else should do it? And I guess I'm curious what people think of that.
Well, I thought it was interesting, like earlier talking about what Jacob was saying about like the responsibility of the outpatient psychiatrist 100% to the patient. And I think for doctors that's generally true, but psychiatrists, we have some responsibility to society, even as an outpatient doctor. We say patients are risking themselves or others, and we involuntarily hospitalize. I mean, that's to the benefit of the patient, but it's also to the benefit of the community. So I think it's interesting here because of the transplant psychiatrists, you have a greater burden of responsibility to the community and society. You should give enough resources from someone else. It's kind of like a balance there. So.
I think the difference that you're pointing to is maybe this false difference between medication and psychotherapy. Like you're thinking of one as a more neutral intervention, or thinking about the other one as inherently not neutral, but you're building a relationship with somebody. And I guess I would argue in both cases you're building a relationship of some kind, and potentially, there's a lot of stratification that you could do within psychotherapy to take, a more active and role. So I liked your thought exercise.
It also brings up questions of access too. So like just pragmatically speaking, someone's sitting in your office and they have a problem and you can like give them a medicine or not, or you really gonna refer to someone else because
I think that tension is implicit, and anytime you bring a patient up, though, to these boards, because you really are saying, like, hey, for everyone, maybe not 100%, but for most of these cases, a transplant is going to be the best outcome. If it's not medically the best outcome, that's done out. That's not going to be on the table for very long. So it does become, okay, well, what are the issues here that need to be addressed? And I mean, who better than somebody who does know that patient? Because when we're on that board, we do really need to know our countertransferences and be able to say, well, from a very objective standpoint, from a very, altruistic and stewardship standpoint, yes or no. And yes, we are human, where biases do get involved there, but I think that's when we question our biases and not necessarily say, okay, because they're here, let's not do that because it's going to be there for every single, I think, treatment provider, unless you're doing like a blind evaluation or you're doing, something that is very much built into being as objective without this human bias as possible.
No, great points. I guess the only thing I would say in addition to that is that I guess in my mind, and I'm curious if the panel sees differently, I feel like this is how I see like donors and recipients as being different in a way, because I feel like with donors, this is medically unnecessary for you. So in some ways, is it your, I guess this is also philosophical, is it your right to donate? Is it a privilege to donate? But with transplant, you're ill. And so the medical role of like, we are going to help alleviate your suffering. We're going to help you get better. If your anxiety is preventing you from coming to medical appointments, yes, we'll say you're not ready now for transplant. But yes, I can help you, whether it's therapy, whether it's medication, with that anxiety so that we can get you to transplant. In the same way that we can prescribe MAT for patients over time and work with them on the inside. But I think the donor side, I guess it's more complicated because, which is why like once somebody has donated, if they have depression and anxiety, actually we do see them at least for consultations because it's kind of like, okay, now you're our patient. But before that, I guess it's an interesting question that are they really your patients right now?
Well, what if they have a simple phobia and they don't want to go to the MRI scanner and they need to go in the MRI scanner so they can be an organ donor? And they want to be an organ donor, but they're just afraid of that MRI scanner. So you shouldn't give them Xanax for that MRI scanner.
So that is an excellent question. I'm curious to think I'm curious to ask what, because we've had cases like that. Well, what do you think of that? Like somebody's a donor, like they're otherwise a good candidate, but they have this phobia of, or maybe blood draws, let's say. What do you think? Like should we help them with that so that they can donate?
I think there's also, you guys are talking about who is your patient. If you're doing an evaluation of somebody, but you haven't treated them in some way with psychotherapy or meds yet, in my head, and also in like a malpractice standpoint of like who's actually your patient or not, if you've given them medications, it's sort of like on record that you're the provider at that point. So, do they have an outpatient provider? Do you supersede that? Do they, it seems like it does get very murky, and I don't think it ever gets talked about as that's so different. For only forensics gets talked about as being so different, but in this case, like if you gave them Xanax to get them into the MRI scanner, you're doing a benefit to them, but now you're their doctor also.
I will also suggest the difference between the patient, the recipient being having a right to the organ and being medicalized, and the donor not having a right to donate and being non-medicalized, maybe more fluid than we think. I'm obviously, if I want to give my kidney to a stranger, that might apply, but I want to take a large risk, maybe, I don't know, not a 1.4%, but a 5% chance of giving my daughter part of my liver to save her life. Doc, I was depressed last time when she was sick. I'm going to jump out a window or be really depressed for the rest of my life if I can't save my daughter's life. That suddenly becomes medical, and maybe saving your daughter's life is more of a right.
One thing that also, going back to the burden to society versus the patient for each different person, like the outpatient psychiatrist, the transplant psychiatrist, for the donor. One example that came to mind is like borderline personality disorder patients. For an outpatient, sometimes we don't diagnose them, even though we feel that they have this because of different conflicts. The patient might not want that diagnosis, they might bring the therapeutic remission, which ultimately is worse for them. But maybe the transplant psychiatrist calls the outpatient psychiatrist for collateral. You're trying to give them a fair history of the patient. If you omit some of that clear cluster B personality pathology because you're trying to look out for the patient, or do you get that information because it's important for the transplant psychiatrist to know? Is it on them to figure that out because their interest is more to society than to the patient? So that kind of, I don't know the answer, but.
And to compound that, your chart may say bipolar 2 because they live in Scarsdale or Chappaqua, and borderline personality because they live in Harlem with the same patient.
And the BPD patients perform a lot worse than one of the presentations. They have like a really bad outcome in relation to non-BPD patients.
I think we were talking about that though at ACLP, one of the transplant, like the safeties about like the reason why they don't make cluster B still like a contraindication, even though because it's a spectrum. Some people it really is like we've had patients where they're possibly relisted and they have a diagnosis of borderline personality, but when they got the first transplant to now, it's a very different reason of like their non-compliance wasn't someone caused more injury and I'm acting out by not taking the meds. It really wasn't like an education thing. What we're trying to say, but basically, like I think with cluster B is a spectrum of how much of that personality pathology is getting in the way of them being able to engage in their care and be compliant with kind of the recommendations that the teams are providing. But they are high risk. Like some can be very high risk, and some are in active treatment, and it's like it's okay.
Nishki, you had mentioned.
Yeah, definitely high risk. So there's like I said, long-standing debate whether it should be a relative contraindication or not. I know, like I said, it's institution dependent, and you're right. When it starts impacting like their care, missing appointments, they don't really have the coping mechanisms, really maladaptive coping to the point where now we're gonna go through transplant eval number 2, which I think I saw with a kidney transplant patient of ours. Then it's kind of, then the committee holds the right to say, well, this was something we offered the resources, we did everything that we can. Patient did not comply. Should this patient be retransplanted at the center? And I think they declined. But it wasn't solely because it was borderline, but they, it impacted their, and this is obviously not a patient that they didn't provide all the resources. They did everything in their power to, short of them attending DBT and doing everything for the patient. So yeah, we've run into these challenges. Interesting thing, we've had LVADs. I think this conversation came up too. Patients who have an LVAD that have this very like a stark kind of personality disorder or like very reactionary kind of impulsive nature. Should we go just straight the transplant route if physiologically possible, right? Because we're afraid that they're going to dislodge the device. I think this was a debate because it's always stressful. I know I've had a couple of patients and I'm always sweating, wondering what's going on with the patient when they're not showing up to any of their LVAD clinic appointments, and what are they doing? Are they taking the warfarin? So it's another thing, like if they are able to, should they just go straight to the transplant route if physiologically, if it's possible anatomically, and there's obviously nothing. So that's also another debate.
Well, I guess also, how much effort does the whole medical team, what's the utilitarian view of the entire medical team sweating and suffering and wondering what's happening if they're putting all this effort into somebody who is constantly people with borderline personality disorder are at higher risk overall of committing suicide because they try more times, but they might not totally be doing as many lethal techniques. Obviously, with an LVAD, there's a very quick lethal technique available to them at that point. But I think I feel like, Akil, you and I saw a patient on the floors that had been transplanted twice with liver transplant, was still using substances, and the transplant team was like, that's it, like we can't do this anymore. And the patient died on the floor because it was too much on resources and the team.
I think a lot of it, what goes down to the fear is the bias. Borderline does have a strong bias that you see a lot of the same with schizophrenia. But as the schizophrenia, someone mentioned before, if they have the proper care, they have good outcomes, because what it really boils down to is behavior. Are they showing up to clinic? Are they taking their meds? Are they a parent or not? Because even borderline, 10 years, treated in remission. So I think a lot of times borderline specifically get targeted as a label or as a diagnosis is because of their behaviors. Because, it's not, they're reactive, they think the black and white. That's usually what leads to these diagnoses. Is that, they're not showing up at the clinic, they're yelling at our social worker, they said they'll be here for next week and then they're not again. And so that's when they say, okay, this is a personality. So I think sometimes maybe targeted behavior can really voice the biases that really do associate with the diagnosis. If that's the point of the diagnosis, that becomes kind of that unspoken sort of tension.
I do wonder if psychiatrists are more biased to borderline personality disorder, though, because I did a research study in medical school, and I asked the medical staff of my university as to whether or not they felt more stressed when they walked into a room with borderline patients. And they were not more stressed. They did not. I mean, it's subjective, obviously, that they feel like they were not biased. But I think they're like, well, call a psych consult and like that, like they'll figure it out from there. But I think we take on more. We're like, oh, okay, let's see what's the.
But I also think ignorance is bliss, because a lot of them
right.
don't know what
they don't know what it is. Just like, does everybody know that alcohol causes liver damage or cancer? Do you guys know? Do they know what they're walking into? Potentially, I think we have a little bit more insight into that.
I'm curious if social determinants of health really get into adherence. So say that someone misses dialysis because they have 3 children, they couldn't make it, versus someone who decides, I don't feel like going, I don't want to go, I'm doing other things, I'm partying, whatever it might be. How do you weigh that in the committee meetings that you're teaching in?
Yeah, that's an excellent question. I think that would be, I think we definitely should, do a better job and keep that in mind in our assessments. But I would say that comes into play in a good psychosocial assessment. So for instance, actually, there was a patient that, would not show up to any of her appointments. And then we found out that she was not literate. She couldn't read, and all the appointments, were basically, print out, but she had so much embarrassment and shame about this that she wouldn't let anybody know. So then, we made sure to always have somebody give her a call before the appointment, etc. Like we, helped set her up for success in that case. But no, 100%. I think that, like one thing is, of course, more broadly moving away from labels. Like if somebody is non-adherent, what does that mean? Why? Is it because of a childcare issue? Is it because of a transportation issue? And definitely social work and psychiatry should, try to see what's going on beyond that's part of our role, and I think certainly keeping equity, social determinants in mind is very important. But I definitely think that historically, I'm sure people have just fallen through the cracks because people didn't have sort of that social determinants of health lens, and I'm sure I'm guilty of many times, this person simply does not show up, they don't take their meds, and maybe I'm not sort of, doing a good enough job recognizing what is the social context of it. But I will say, like, thinking of all these psychometrics, right? Like, so scales, like the PsyPAD, LDAT. So I will say, just as we've talked about, if somebody is unhoused, for instance, generally they're not considered to be a candidate for a transplant because, we argue that they don't have stable housing, they don't have hygienic environment to take care of themselves, as well as avoid infection, store their meds, etc. But isn't that a huge equity issue? Or if somebody's incarcerated? So there's all these factors, social support. So
I was just having a conversation with a kidney surgeon, Dr. Ratner. He, he's saying, our follow-up is the people are I said, our liver transplant patients, all the recipients, it's like 100% show up for all their appointments. And they're just so good about coming in. They're sick. They're very motivated to get to transplant. The kidney patients, not the same. And they miss their appointments. They're not coming. And part of it is that they're all on dialysis. And their dialysis doctor's saying, I mean, there's a whole conversation that's happening outside of the transplant evaluation. It's transplant, and so I think there's biases outside of our rooms, right? So there's what is it that the patient, you can say, oh, the patient's not motivated, but it's really about choices, and you're giving them those opportunities to kind of make it. We extend their evaluation time in kidney. We like to see them get there, but at some point, yeah, I mean, after seeing psychiatry, social work, and we're trying to be, in a way, uncover all these potential hidden social determinants of health, and then you go through all of that, and they're still not showing up for their appointments. It is the behavior in the end. It's the outward. It's what are they doing? Are they coming to their appointments, or are they not? If they're not coming to their appointments, I mean, you could go on and opine about how motivated they are or whatever, but in the end, they're not going to be a transplant candidate.
Or you could motivate them. The way you can motivate them is you could figure out the lifetime cost of dialysis for that patient, take it in cash. Every time they show up for their appointment, give them $50. And the system would probably save money, and they'd have motivation to show up. But viscerally, people don't feel comfortable doing that. Food for thought.
If people are paid for their appointments,
Yeah.
it's contingency management.
There is a surgeon at my facility who is like, for all these alcohol patients that we're transplanting, we should just pay them. They'll probably remain more sober if we're paying them for the number of months that their pets are negative.
The data backs that up.
Yeah.
But people are, I mean, this is
I know.
a random news
I know.
association, but people are paid to go use the gym in some jobs.
Yeah.
Start
paying them for the pets.
I'm sorry, I have a lot of questions. How do you all, and if it's a personal question, that's fine, but how do you navigate when either you said just pick those communities where it's like, this is a high-risk patient, or there is a patient who you hope that they'll get listed even though you did the assessment, and either you recognize the team, that they decline them, or they go opposite of what you were hoping for in a way, or you feel like maybe there's a lot of counter-transference in the room and you're not, how do you kind of navigate that for yourself? Or if you notice maybe there's a particular other person in the hepatologist who they have a lot of counter-transference that's kind of bleeding into the room on multiple occasions. How do you navigate that?
It's a great question. I mean, I think I have a good relationship with our hepatologist. I think so I work on the same floor. Their offices are around me, so having conversations outside of the meetings is really good.
That's an excellent point. I mean, that's a brilliant point, because I think that, when you do CL for the most part, it's often new teams, new players. And so that kind of regular CL, outside of transplant, and that can make it hard because, there's a new hospitalist on service, there's different players. But I think that the thing with transplant is that you have the ability to build relationships. So, yeah, I mean, I certainly feel that, for instance, in the donor review committee meetings, that it is a group of people that I have a level of comfort with, in advocating. I think the recipient meetings are a little bit larger, but that's a good point. That relationships outside of just, and like they say with anything in life, right? The first time you talk to somebody shouldn't be when you want something from them. So.
Usually it's the last time you talk to them.
I agree. I think relationships that's kind of even the building blocks for building the service. If you're present and available for them from the beginning, they're willing to listen to kind of your rationale. Every team dynamic is different. It's a little bit more challenging with my cardiology colleagues than my liver. My abdominal ones are amazing. Cardiology can be a little challenging, but then that's when I use the term. I'm not the gatekeeper. If I feel that this patient is a high risk, I did my assessment. If there's a medical necessity, they're taking on that risk too, right? So that's how you have to kind of let go, because I know sometimes it feels kind of challenging going back and forth and just kind of letting them know this is not a good idea, but there's a medical necessity. So, or the patient has a daughter or son. They always kind of bring up the sob story at that time, but they're like this patient, and so you're like,
Yes, there've been many times I thought I was coming into a transplant meeting to drop a bomb and be like, we can't transplant this patient. They're like, we're going to do it anyway. Yeah. Well, on that note, I just want to take a minute because we'll end on time essentially, and thank all of our panelists here today, and thank you guys for coming and being discussants with all of us. So, round of applause for our panel and our fellows, and good luck with fellowship and everything. Feel free to reach out. Like I said, March 27th is our winter mixer. And if you aren't a member of the SLP and you want to be, email us and reach out. But thanks, guys. Have a great rest of your day.